Dear ladies and gentlemen, a very good morning to all of you. Welcome to the education seminar and webinar on hypertension management organized by Diabetes, Endocrine, Cardio-Renal Trust in collaboration with the Non-Communicable Disease Unit of Ministry of Health. This event is organized to celebrate the World Hypertension Day, which falls on today, May the 17th. Under this year's theme, measure your blood pressure accurately, control it, live longer. We are here to discuss latest clinical and academic findings and knowledge about hypertension in front of a very enthusiastic looking crowd ranging from budding young medical students to top tier medical and academic professionals. Sadhane?
Thank you, Indora. The Diabetes, Endocrine and Cardio-Renal Trust was founded in 2019 with 6 directors and Professor Prasad Katlanda as the chairperson. Since its inception, it has been actively involved in various initiatives and has always been committed to make a positive impact on the health and well-being of society. To commemorate World Hypertension Day in 2023, Diabetes, Endocrine and Cardio-Renal Trust collaborated with the Rural Health Research Centre in Kathragama, which is affiliated with the University of Colombo, to organize a medical camp along with an educational and awareness program just like this. The Non-Communicable Disease Unit was established in 1998 under the Ministry of Health. This program plays the main role in planning, implementation, monitoring and evaluation of interventions and initiatives for prevention and control of NCDs in the country with the aim of working towards a country free of this avoidable burden while promoting healthy lifestyles among our community.
Yes, Sadhane. So without further delay, to mark the commencement of today's event by lighting the traditional oil lamp, we are honored to invite today's chief guest, Dr. Palitha Mahepala, Secretary of Health,
Dr. Kumara Vikramasinghe, Deputy Director General, National Hospital Sri Lanka,
Dr. Samendhi Samarakon, Director, Non-Communicable Disease Unit,
Vidya Jyoti, Professor Prasad Katlanda, Chairman of Diabetes, Endocrine and Cardio-Renal Trust, Head of the Department of Clinical Medicine, Faculty of Medicine, University of Colombo,
Dr. Pradeep Ratnasekara, Deputy Director, National Hospital Sri Lanka,
Dr. Indika Jagoda, Deputy Director, National Hospital Sri Lanka,
Dr. Rokshan Bellana, Deputy Director, National Hospital Sri Lanka,
Dr. Upul Disanayaka, President, Ceylon College of Physicians,
Prof. Priyanka Ranasinghe from Department of Pharmacology, Faculty of Medicine, University of Colombo,
Dr. Dilushi Vijayaratna, Lecturer in Department of Clinical Medicine, Faculty of Medicine, University of Colombo,
Dr. Anidu Patirana, Consultant Cardiologist, National Hospital Sri Lanka,
Dr. Chandrika Subasinghe, Consultant Endocrinologist, Colombo North Teaching Hospital,
Dr. Niranjala Meguda Vidanage, Consultant Endocrinologist, National Hospital Sri Lanka,
the Directors of Diabetes, Endocrine and Cardio-Renal Trust, Professor Pujitha Vikramasinghe from Pediatrics Department, Faculty of Medicine, University of Colombo,
Professor Upul Senarath from Community Medicine Department, Faculty of Medicine, Colombo, University of Colombo,
Professor Roger Constantine from Clinical Medicine Department, Faculty of Medicine, University of Colombo,
Professor Ranga Vijay Vikrama from Clinical Medicine Department, Faculty of Medicine, University of Colombo,
Diabetes, Endocrine and Cardio-Renal Trust Fund member Dr. Manilka Sumanathilaka, Dr. Udita Bulugahabitiya, endocrinologist.
Thank you, dear ladies and gentlemen. I'm sure this will mark a successful and enlightened start for today's session. So, going on, now, in order to welcome everyone, I would like to invite Vidya Jyoti, Professor Prasad Katulanda, Chairman of the Diabetes, Endocrine and Cardiorenal Trust, Professor and Head of the Department of Clinical Medicine, Faculty of Medicine, University of Colombo, to deliver the welcome address.
Good morning, everybody. Dr. Palitha Mahipala, Secretary Health, Dr. Kumara Wickramasinghe, the Deputy Director General Health Services, National Hospital of Sri Lanka, Dr. Samidhi Samarakon, Director NCD, Deputy Directors of the National Hospital, Dr. Upul Disanayaka, President, Ceylon College of Physicians, and my colleagues from the National Hospital, the consultants, doctors, nurses, medical students, media, ladies and gentlemen. Actually, the Diabetes Endocrine Cardiorenal Trust had been marking important events of health that causes significant mortality and morbidity and burden to our society over the last few years. We had done screening programs, particularly in the rural areas like Kataragama last few years. And this year also we thought we should mark the World Hypertension Day, not celebrate, because to enlighten the public on its importance and what we should do as a society. So first of all, let me warmly welcome our chief guest, Secretary of Health, and all the other dignitaries and all of you to this important event to mark the World Hypertension Day, where we are going to have educational program here and which will be webcasted across the country so that many people will be benefited from this program. So this year's theme, as it was mentioned, is Know Your Blood Pressure and Control. I will enlighten later on why it is important for everybody to know our hypertension and the blood pressure level and its significance. And everybody knows that sustained elevation of blood pressure is the definition of hypertension. And I'm sure Dr. Anindu in his talk will go into details about the classification and the guidelines. Usually there is normal blood pressure or optimal blood pressure, and then hypertension had been graded into several grades, and sometimes this is made confusing because various guidelines, various societies come up with many, slightly different classifications, but we should stick to something uniform. The problem with hypertension is that it is a silent condition. Unless you get a stroke, unless you get a heart attack, unless you get into heart failure or kidney failure, none of us, if we have hypertension, get any symptoms. Sometimes when it is very high, we can get a headache, but usually most people says, they have headache and high blood pressure, but it is not usually commonly to cause symptoms. Yet we know that it is a huge public health problem because it is the most common risk factor for stroke. In addition, it is a very important significant risk factor for kidney disease and heart disease, particularly heart failure, and there are many other conditions including the visual loss and even attributed to bone loss, sexual problems, and depression, anxiety, and so it is a huge health problem. Now, according to world data, 1/3 of adults suffer from hypertension, but this can vary between different countries and different genders, different age groups. And then usually, as a rule of the thumb, about 1 in 3 adults don't know that they have hypertension, but again, this can again significantly vary. In sometimes we had about 50% of our population did not know that they have hypertension. And also, even in patients with hypertension, significant proportion, I will show some eye-watering data as we go on later. Actually, in one of our studies done about 10 years ago, most of the patients with hypertension, even with conditions like CKD and heart disease, were not optimally controlled in their high blood pressure. So this is very important for all of us to know. We know that there are non-modifiable risk factors like our ethnicity, age, and genetics as risk factors. And then there are a whole lot of modifiable risk factors like high salt intakes, smoking, other health problems, inactive lifestyle, alcohol, high stress levels, obesity, all of which are modifiable risk factors for hypertension. The other important thing for all of us to understand today is that hypertension is preventable. Although it's a very dreadful condition, it is preventable and controllable by even simple lifestyles like healthy diet, reducing our salt intake, increasing our green vegetable intake, and also reducing our body weight and our waistline, and taking aerobic type physical activity, avoiding tobacco, avoiding harmful intake of alcohol, and having mindful and stress-free lifestyle, and also adequate sleep. So in addition, the hypertension and its complications worsens inequalities in society, make poor people poorer, and causes hardships to their families, and increases the burden on our very difficult running health systems because of issues like stroke, kidney failure, which are very costly conditions to manage. Hypertension needs a multifaceted approach to tackle the issue, and the countries should have their national guidelines and protocols to coordinate and monitor. So I'm very delighted that we have the highest official from the Ministry of Health who is involved in decision making here in this ceremony, and who is also a very experienced official in the Ministry of Health. I'm sure that his guidance will help in the control of hypertension in this country. In addition, the NCD unit is a collaborator, and NCD unit with the NCD policy. Sri Lanka is one of the few countries that came up with the NCD policy even more than about 10 years ago. So we have our policies. So the important thing is everybody to get together and implement these policies, including the society, the public, and the media, and all stakeholders, so that we'll be able to reduce the burden of hypertension and its complications and make our population healthy. Again, I would like to thank all of you for being here today, and hopefully that we'll be able to disseminate the message across the country. Thank you very much.
Thank you, sir. And now, please welcome Dr. Samindi Samarakon, Director, Non-Communicable Disease Unit, to share her insights regarding today's proceedings.
Good morning, Secretary Health, DDG NHSL, Professor Katulanda, all consultants, all the staff of NHSL, including the CNO, and 2 deputy directors. So it is a special day for us. Non-Communicable Disease Unit, Ministry of Health, together with the Diabetic, Endocrine and Cardiorenal Trust and National Hospital Sri Lanka, are gathered here today to commemorate World Hypertension Day 2024. Our health system stands as the backbone of the society, designed to safeguard the well-being of every individual. Yet, despite its advancement, hypertension continues to pose a significant threat to global health. Hypertension, often referred to as the silent killer, affects millions worldwide and is a leading cause of heart disease, stroke, and other life-threatening conditions. So 83% of our deaths in Sri Lanka are due to non-communicable diseases. Among those, 45% of deaths are premature, that is less than 60 years. Recent STEP survey is a 5-yearly survey done by the WHO, the Department of Census, and together with the Ministry of Health, NCD unit is involved in the analysis of this data, shows that on an average, 35% of our population are hypertensive, and only 20% of them are having blood pressure under control. So this is a dangerous situation. Further, this survey reveals the risk factors of these non-communicable diseases. So it says 48% of females and 30% of males are overweight. 35% of the people still add salt into rice. 64% of the population are with no recreational activities, and 24% of males and 44% of females are physically inactive. So both sexes, 14.2% are having risk for CVDs. So this is a very dangerous and bad situation of the country. As the Non-Communicable Disease Unit, Ministry of Health, with all our stakeholders, work hard to control and prevent NCDs. Island-wide, we have 1,026 healthy lifestyle centers for screening, identified designated medical officers for NCD, MONCDs, with given responsibilities. The unit reviews them quarterly, and through multi-sectoral action plan with identified targets, both preventive and curative health staff put their maximum efforts to make this target a reality. Highest percentage of GOSL or government allocations are for the control of NCDs. However, with all these positive approaches, we still face challenges which need urgent intervention. The burden of hypertension extends far beyond individual health. It strains healthcare resources, hampers economic productivity, and diminishes overall quality of life. Therefore, it is essential to address hypertension comprehensively within our health system. First and foremost, our health system must prioritize prevention. Health Secretary Mahipala sir always highlight this factor. The prevention is very important. And education and awareness campaigns are fundamental in empowering individuals to understand the risk factors and adopt healthy lifestyles. By promoting regular exercises, balanced diets, and stress management techniques, we can mitigate the onset and progression of hypertension. Furthermore, access to affordable and comprehensive healthcare services is paramount. Regular screening for blood pressure, coupled with early intervention strategies, can effectively manage hypertension and prevent its devastating consequences. It is incumbent upon government and healthcare providers to ensure equitable access to these essential services, particularly in the underserved communities where the burden of hypertension is often acute. Additionally, our health system must embrace innovation and technology to enhance hypertension management. Telemedicine, it is partially implemented in the health system in the country, and wearable devices and digital health platforms. Actually, under 2 projects, Diabetic Compass and Resolve, we have initiated, the NCD unit has initiated this project in Kalutara and very recently in Kandy, using digital health platforms to check the control of hypertension of our population. So these new interventions will provide personalized intervention and improve patient outcomes. By harnessing these advancements, we can transcend traditional barriers to care and deliver more efficient patient-centered solutions. However, addressing hypertension within our health system requires a multisectoral approach since it is the multifactorial disease. Collaboration among healthcare providers, policymakers, research communities is essential to implement evidence-based strategies, allocate our resources effectively, and foster a culture of prevention and wellness. As we commemorate World Hypertension Day today, let us reaffirm our commitment to building a health system that not only responds to the immediate needs of individuals with hypertension, but also address the underlying determinants of health. Together, let us strive towards a future where hypertension is no longer a silent killer, but a preventable and manageable condition for all. Thank you.
Thank you, Madam. Now we would like to invite our chief guest, Dr. Palitha Mahepala, Secretary of Health, to share his perspective in marking the World Hypertension Day.
Good morning to everybody. The Deputy Director General of National Hospital, Dr. Kumar Vikram Singha, the Director of NCD, Professor Katulanda, two Deputy Directors of the National Hospital, all the other distinguished participants, Dr. Udita Bulugahapitiya, Dr. Upul, and all the other consultants who are present here today, ladies and gentlemen. It gives me great pleasure and honor to be here today at the ceremony organizing to mark the World Hypertension Day. We have different days identified by World Health Organization and many other such international organizations to raise the awareness among different issues. Today, when we mark the World Hypertension Day, non-communicable diseases are much on the increase. Globally, annually 41 million people die due to NCDs. NCDs are basically the cardiovascular diseases, cancers, diabetes, and chronic obstructive airway diseases. So 41 million people die due to these NCDs globally. And in Sri Lanka, 89% of the mortality is due to NCDs. It's quite high. And over the last 20 years, we have seen it increase from 70% to 89%. So progression is very high. Among the 41 million deaths taking place globally, 17.2 million deaths are due to cardiovascular diseases. 10 million roughly is due to cancers, and rest is due to diabetes and chronic obstructive airway diseases. If you look at the prevention side of it, there are 4 risk factors for NCDs. Unhealthy diet, which include high sugar consumption and high salt consumption, which is true for our country. And then smoking or tobacco, then alcohol, and then physical inactivity, which leads to overweight and obesity. I think figures have been highlighted by Dr. Samindya and Professor Katulanda very well. Sri Lanka, 35% of the population, adult population, is suffering from hypertension. And 2/3 are not under control, only 1/3, 30% is under control. Hypertension is a simple disease which can be treated well in primary health care setup. That's why we are now trying to have primary health care reforms to have an integrated care delivery with comprehensive services to treat hypertension, diabetes, and other non-communicable diseases. The elderly population in the country is increasing. Life expectancy in Sri Lanka has reached now 80 years, which is quite high. Highest Australia and Japan, which is 85, and Sri Lanka females have reached, the recent estimates tells us it's 83 years, quite close to the Western developed countries. But for males, it's 78. There's 5 years there where females live longer than males, and males die early because of cardiovascular diseases. So the risk factors, I told, alcohol, tobacco, unhealthy diet, physical inactivity. And there are another 4 risk factors, so we call metabolic risk factors. One is high blood pressure, hypertension. Other one is high blood sugar. Then of course, high BMI and so on. So hypertension is a metabolic risk factor for many non-communicable diseases, particularly the cardiovascular disease, myocardial infarction and strokes. In Sri Lanka, because hypertension is not well under control, where we need to really get involved with the public awareness program, 60,000 people reported to the health system in the country, public health system, with strokes, and 4,000 die. You can imagine probably equal number is getting strokes who are not coming to our system, go for other treatment. So numbers are quite high, but if we can have hypertension well under control, which is a simple intervention, this wouldn't have happened. We can save 4,000 lives. Then how many die due to infarction? Quite higher than number die due to strokes. So therefore, this is a serious issue. People are unaware. We need to talk about the unhealthy diet, reducing the salt in our diet, reduction of sugar consumption. We have brought forward many regulations like traffic light system for sugar, and we are recommending to the government to increase tobacco taxation and also increase taxation for sugar as well, we call SSB taxation. So these kind of population-wide interventions are important. Then of course we need to make the general public aware about unhealthy diet, the importance of physical activity, which reduce the mortality due to NCDs. I don't think this time that I should go on talking on this. We are really focusing as government on primary health care reforms to have an integrated service delivery at the primary health care level, where we give the comprehensive treatment for NCDs, diabetes, hypertension, then of course other chronic obstructive airway diseases, which will be help us to reduce the mortality in the country due to NCDs. So I am extremely thankful to Prasad for inviting me, and we are very much thankful to the DDG NSL and the organizing committee for organizing this great event. I am sure that during the course of the day you have deliberations, lectures, and so on to enlighten our medical profession on the guidelines, protocols to deal with hypertension. So these are the important workshops we conduct, and I am so much thankful to each one of you for presence here today. And government is taking all the steps to ensure public awareness and ensure availability of comprehensive treatment at the lowest level, the primary health care level, to deal with this NCD disease burden. So I wish all your deliberations a success. I'll stop here. Thank you so much.
Thank you, sir. And now, please welcome Dr. Kumara Wickramasinghe, Deputy Director General, National Hospital Sri Lanka, to speak a few words about today's proceedings.
Dr. Palita Mahipala, Secretary Health, Dr. Samindhi Sambarakon, Director Non-Communicable Diseases, Dr. Rukshan Belan and Dr. Pradeep Ratnasekar, Deputy Directors, Professor Prasad Katulanda, Dr. Pulsa Nayaka, and all other consultants, nursing staffs, doctors, invitees, ladies and gentlemen. Let me first thank Professor Prasad Katulanda for inviting me on this very important occasion for the commemoration of World Hypertension Day. As it was mentioned from this place already several times, I'm not going to talk about any statistics, but the message is probably some people who are sitting here having hypertension and know that they have hypertension. Some people are sitting here having hypertension, they don't know that they are having hypertension, and some are candidates. Why? Well, I think our lifestyle, food, many have changed for decades, but it has not changed our genetics. Probably our predisposition for the hypertension is high. Therefore, we have 1/3 of people having hypertension. And second thing is now, hypertension, as a simple hypertension, if you control it, probably we can save a lot, because our health is free at a point of delivery. Now, two things coming out of that. If you are not controlled, you might get end up with having a stroke or some other illness, severe illness, which is burden to health system and the country. If you if you are not controlling it. If you are controlling it, then we have to be ready to treat everybody, because many people will come to our system. Majority people will not be able to go to private sector and get the treatments. So we have to be ready for that. But if we do it, that will be less costly for the health system and the country. So I believe that we should be doing to inform the people who are not aware about their underlying illnesses, so that they will start their treatment on time. Second thing, even we inform people, we diagnose the thing, many people in the country, we know, they do not heed the medical advice, do not take medicine properly. So as a medical professionals, it's our duty to inform them scientifically that they will get the message, the importance of controlling hypertension in their lives. That all depends their family, then they depend their economy, and then at last it's a country, how it look at. And I'm happy that NCD unit, the non-communicable disease unit for the Ministry of Health, and the staff has taken seriously for the last few years, maybe decades, on the NCD prevention in the country. So best thing is to prevent. If you prevent it, it's less cost to the government, less cost to the country, and people will be more healthy. So as I already said, if you control it, it's less burden. So let us work, get the message to people in order to get this thing at least somewhat controlled. And next year, maybe next few years, we might say that it's not 35%, maybe less than 30% if you work hard. But it's a difficult task. And also, it's important to update our knowledge. So I believe today's deliberations definitely will give you new insights about the hypertension, so that we get ourselves updated, so that we can get the correct message to the population. And as an administrator, I would like to see less people in the hospitals, because we are worried about the quality of care. And I wonder whether how many people are correctly measured blood pressure in our OPDs, especially like National Hospital. Some clinics, we get 1,000 people a day. And so Secretary Health correctly said that we have underutilized primary care, and the simple hypertension and simple NCDs could be managed at that level, so that burden of the tertiary care and apex hospitals reduced. I hope that Minister of Health, together with the NCD unit of the Ministry of Health, will work hard to get this thing a success. We as the administrators, as a professional college, also trying hard to get it improved in order to improve the quality of the care in the bigger hospitals so that people will go to the simple illnesses to the primary care. So I don't want to speak at length anymore. I think you have more important things to listen other than me. So let me again thank Professor Katulanda and his team for inviting me. Also wish you are a very successful workshop today. Thank you.
Thank you, sir. And now I would like to invite Dr. Upul Disanayaka, President, Ceylon College of Physicians, to share his thoughts.
DDG NHSL, Director, NCD, Deputy Directors, Consultants, ladies and gentlemen. Thank you for inviting the College of Physicians to share its thoughts with you today for Professor Prasad Katulanda. The DDG made a very valid point that our blood pressure measurements are not that accurate. Say in a clinic full of about 200 to 300 patients, to be cleared and sent home within 4 hours is not an easy task. So may I suggest to the Ministry of Health, the DDH, NHSL, NCD unit, that we need these automated blood pressure high duty machines, not the small battery operated machines, where the patients can check their blood pressure on their own. And I've seen this in other countries. It's possible, now it will be cost effective in the long run. And you have worked hard to bring our the mortalities down and increase our life expectancy to 80s. But remember that while some of these life expectancy the last couple of years will be spent on the bed and as demented people or with shortness of breath and difficulty in walking here and there. So, and most of the time the patients are worried about the side effects of these long-term drugs and they think that it's a curable disease and they stop it when the blood pressure is low. So let's tell the importance of continuing the antihypertensives on long-term basis. When they come and ask me how long that they should be taking the antihypertensives, I tell them, and have a good day, and we wish very productive World Hypertension Day and imparting knowledge to all of us. Thank you very much.
Thank you, sir. So now let's move to the lecture series on hypertension. Our first lecture for the day is under the topic of hypertension in Sri Lanka. Please welcome Vidyajyoti Professor Prasad Katulanda, Chairman, Diabetes, Endocrine and Cardiorenal Trust, Head of the Department of Clinical Medicine, Faculty of Medicine, University of Colombo, in order to deliver the lecture.
Thank you. Actually, my task is to set the stage for the latter part, other lectures that you are going to hear, so that you know the importance of hypertension. So this is the distribution of death, leading causes of death in the world. You can see cardiovascular diseases, which include ischemic heart disease, stroke, and perhaps heart failure, is the top most important cause. So that is why we are having this program today. And Dr. Anand will touch upon the classification. And I have already mentioned about this silent problem. Because unless you have complications, we don't know unless you measure blood pressure. And we have mentioned about the risk factors and the very important complications. The most important risk factor for stroke is hypertension. And then for kidney failure, along with diabetes, hypertension is one of the most common risk factors. We see many patients with only hypertension as the risk factor who develop kidney failure. Similarly, we see many patients coming with heart failure, only risk factor is hypertension. Then severe uncontrolled blood pressure can lead to vision loss, also heart attack, sexual dysfunction, and many other complications. I have told about this 1/3 rule. And this study, one of the great landmark studies in cardiovascular disease, epidemiological studies called Framingham Heart Study, is the one that elegantly described the risk factors for heart disease quite early, several decades ago. And you can see elevated cholesterol, hypertension, diabetes, cigarette smoking, in all age groups, they showed the association with heart disease. And then many studies pulled together, these data show how with increasing blood pressure, how the relative risk of stroke increases. You see, it goes very exponentially, the curve. Whereas if you take the coronary heart disease, it increases, but not as high as for stroke. So for stroke prevention, hypertension is very, very important. And again, same data, they have divided between optimal blood pressure and then normal blood pressure, high blood pressure, and how over the years the incidence increases if that goes on. And then we now know the association between elevated blood pressure and the complication. It is just not useful to know this, and it's very useful to know whether the controlling of that risk factor is useful. Now, these studies have shown that controlling, here it is diastolic blood pressure, these are observational studies, these are drug treatment trials. You can see with increasing reduction of the blood pressure, there is reduced coronary heart disease and stroke, but more effective for stroke prevention. So we have good data to show that hypertension control is beneficial. So hypertension is a major treatable risk factor and very independent risk factor for many conditions that I have already mentioned. And then the relationship is continuous. Even if you reduce the blood pressure by 1 millimeter mercury, there is some benefit. And also this benefit is incremental and continuous. These are the very important things to understand. Just to highlight the sort of the trajectory of hypertension in this country, this study, actually this was published in 2004, showed that hypertension is about 20% in men and women. Now, then we did this study called Sri Lanka Diabetes and Cardiovascular Disease Study in 7 provinces, about screening about 5,000 people. At that study, we showed that in people above 20 years, the blood pressure prevalence is closer to 30%, 28%, but little higher in the urban compared to rural. But if you look at diabetes, this difference is very much more. So hypertension actually hardly any difference in the urban and rural like prevalence, and actually this p-value is not significant for males versus females for these two sectors. And so we have to understand this is important both for rural as well as urban areas. You can see here known versus unknown hypertension. So quite equal percentage of people with hypertension don't know, nearly about 50% don't know that they have hypertension. That is another important thing. And also we know we are one of the very rapidly aging populations, and if you look at the age group above 60 years, more than 50% has hypertension. So with increasing age, we are going to have many people with high blood pressure in the society with their with its added complications. And now we know about that there's a condition or category called pre-hypertension. So there's a lot of people with marginally elevated blood pressure also. So that these people, unless they take measures, they will go into develop full-blown hypertension. And both taken together, more than 40% of the people have either pre-hypertension or hypertension. So compared to other countries, actually Sri Lanka is one of the high prevalence countries compared to even India in the region, slightly less than developed countries like US, UK, and Australia. So now I'm going to show you some interesting associations. So where this is useful for all of us as well as to our patients in prevention. You see increase in waist circumference and the increase prevalence of blood pressure. So more your waistline is, the more chances that you are going to have high blood pressure. So again, similarly, the BMI, the more obese you are going to have higher risk of high blood pressure. Again, there's a reverse association between physical activity. You see the proportion of people with physical inactivity, about 40% have hypertension, whereas those who are active, it's about 20%. So if you are physically active, it's going to be helpful. And again, income, actually there's not much of a major association, so P is not significant. So unlike diabetes, where it is common in high income, again which is changing, the poor people are getting affected quite more, and this might overtake the rich people who are eating more healthy diet, more exercise and so on. So which we are seeing an epidemiological change for diabetes also in this country like the West. So but hypertension is not very common in high income groups, but actually you can see it's even slightly higher in the lower income groups compared to the high income people. So this is another study published done between 2018 to 2019, large study called Sri Lanka Health and Aging Study, that showed a higher prevalence of hypertension compared to previous studies, 28%, and particularly in that study, of course, compared to the rural and plantation sector, the rural, other rural, non-plantation rural and urban has high blood pressure. And this is actually, you can see the main difference I think is because even in our previous studies we have shown that people in the plantation now very thin. So this is the problem, the association which is beneficial to them in terms of hypertension. So this is, you can see the similar data to what I have shown before. People more than 60 years have more than 50% high blood pressure. This is again very eye-watering data as for a doctor community. You can see tertiary hospital clinics, community, the controlled blood pressure is about 25%. So we have to think ourselves what we are doing. Perhaps it's our inertia, partly due to the patient's attitudes of non-compliance, because a lot of our patients have myths about the safety of NCD-related drugs like diabetes drugs, antihypertensives, and this may also be contributed. But again, we should be blamed for those myths because as medical fraternity, we should be educating the people. And you can see the diastolic blood pressure, the control is about just 51%, and the systolic even lesser, and both systolic and diastolic it's about 26%. And you can see even in patients with diabetes and ischemic heart disease, see the lower levels of control, which are eye-watering, and overall this male and female levels. So, ladies and gentlemen, more than 1 in 4 Sri Lankan adults have hypertension, both males, females, and urban, rural, quite equally affected, and there's an exponential increase with the age. Where very clear data to show the association with obesity and physical inactivity. And then nearly half of the people with hypertension are unaware of them having the condition, and also majority of the patients with hypertension are inadequately controlled. Since we don't have a lecture on prevention, just few thoughts about the prevention or non-pharmacological control, healthy diet. Very few things we can do. So by doing few things, we can have major impacts. Low salt diet and high fiber diet and less alcohol is going to help us prevent hypertension as well as help in controlling that. Aerobic type physical activity, avoiding smoking, managing stress, and improving our overall health by being mindful, having adequate sleep, and even doing things which improve mindfulness, like even yoga and so on. So, ladies and gentlemen, we have a health problem that is quite not very apparent over the outside, but it is a silent problem, but it is causing many issues to our people, and we have things that we can do to address this, prevent this, and we have lined up a series of talks by experts in the relevant fields to enlighten you how we can tackle this problem in different scenarios. Thank you very much for your patient listening.
Thank you, Prof. Prasad Kadlanda, for that interesting, I'd rather say eye-opening lecture about hypertension in Sri Lanka. Next in line with the lecture series that we are conducting today, marking the World Hypertension Day, we have Dr. Anidu Pathirana, Consultant Cardiologist, National Hospital, Sri Lanka. Dear sir, the stage is yours.
Just okay, yeah, you have no, that's okay.
Thank you.
So, good morning to all of you, and first of all, let me thank Professor Prasad Kadlanda for inviting me. So I'll be talking about how to evaluate and manage a patient who does not have an identifiable underlying cause, that is primary, we call primary or essential hypertension. It comprises about 90% of the hypertensive disorders, and because only 5 to 10% you can find the underlying cause. So my talk will based on the latest scientific evidence about the subject of hypertension, which is coming from European Society of Hypertension, published in December 2023, and it's a very vast document, about 150 pages, and a lot of people experts have given their inputs, and so that is the latest. I will basically, as far as the science is concerned, my things I will be discussing will be based on that. And the second document that I'll be focusing is 2020 International Society of Hypertension, who didn't summarize evidence, but they harmonized, because there are a lot of controversy even among the scientific community about these various definitions, what to do, and they harmonized all that time available Japanese, American, and European guidelines and produced something relevant to the global setting, because they were telling about all the interventions. They categorized essential and optimal categories. Essential categories should be able to do it in a low economic setting. A country like ours, our economy is devastated, and they are applicable to us. And there are optimal things which can be advanced, very costly procedures. They have categorized. So my talk will be based on those documents. And I'll be talking about, my approach would be, as you know, blood pressure inside our arterial system is an essential biological attribute. So you need blood pressure in our arteries to maintain the tissue perfusion. And when it comes to the human population, it's a biological variable, because there's a normal kind of distribution, and there's a high end and a low end and middle. And so experts draw a line, arbitrary line from time to time, and draw a line of blood pressure, and higher than that, they say, define as you have hypertension, a disease, right? And so I will be talking about how they do that. And then, as I said, this is a vascular disease, so vessels will suffer, and when the vessel, your health is the vessel, your vessel, health of the vessel, your age is the, our age is the age of the vessels, and especially the endothelium. So how this hypertension damage the vessels and the supplying organs. So when it happens, most of them end up in atherosclerotic cardiovascular event, and some of them die, unfortunately, persons, and some of them survive and have disability. So I'll be talking about this risk and how to do, what can be done about all of them, right? And so that will be next. So as you know, blood pressure inside the arterial system had to be measured. So best way to measure is to put a catheter into the aorta, that measure the central blood pressure. That is the most important attribute that can be related to the outcomes. But we can't be doing that in general setting, so we have to depend on the non-invasive measure. We can nowadays non-invasively measure the central pressure also, but they are not validated. So the goals, what we do is non-invasively measure the peripheral pressure, and there are two kinds of devices that you can be used. You use a cuff and apply it in the upper arm, and so that is the default for the long time. And so there are, then detect the blood pressure, you use the auscultatory method, use a stethoscope, or by the wave pattern oscillometry, they can detect, digitally can detect. So at present, automated cuff-based electronic devices are the preferred mode, even in office setting, that is office means clinic setting. So if you don't have that, then there's now hybrid, because mercury is out because of the environmental risk, and there are hybrid sphygmomanometers which are cuff-based. So what is important to know it, all these devices has to be validated according to the established criteria. But problem is the regulations are there, but nobody to govern. And the world market is having lot of devices which are not validated. So the European guideline sets us the various internet sources to identify what we have, the pressure, whether it's a validated or not pressure instrument. That is very important. Otherwise, if you don't use the proper one, you measure the wrong thing. And when you have use it, the things can go wrong. Then it has to be recalibrated yearly by the manufacturer, the agent of the manufacturer in the country. And one important thing, office where we use the ambulatory devices, cuff devices, have to be calibrated. Our blood pressure meter in the ward, but it is, I don't know, in certain whether it has to be labeled, it was seen, calibrated on this day. You can go and see your wards whether that label is there. Otherwise, you are measuring wrong thing. And important things what we use in digital small meters at home, they need not to be calibrated very frequently, and just to see what is somebody decide what is their rubber tubing looks like. That is one of the important thing about the small device. So blood pressure can be measured in real life, two different settings. One is at the clinic and one is at the outpatients. So for the time being, if you want to diagnose blood pressure, it is somebody has to measure your blood pressure and at a clinic. So that is the standard. Unattended blood pressure, it was talked about previously. It's not validated for diagnosis, but it can be used differently. When you come to diagnosis, you have to make that. And out of clinic, that means if you use a blood pressure meter at home or with ambulatory blood pressure, they can be useful to maintain measure the maintenance of the care. So whatever the way you do, the measurements has to be accurate. So there are the societies, various put essential standards on the conditions, essential standards on the posture, and essential standards on the measurement, especially regarding home measurements and office measurements. And it is usually, what we take is the seated blood pressure, and this is how it has to be seated. There are various standards, and before you do that, you have to, the environment where you measure the pressure has to be standard, and also you should empty your bladder, should not have been smoking 30 minutes before, that kind of thing. And how do you measure also, there are specifications. So this is a tedious process. To do this cycle, only it will take about 5 to 10 minutes. So whereas, so to prepare the patient before that, it take another 10 minutes. So it's a 15 minutes affair. So it has to be done. So otherwise you are giving an asymptomatic person different diagnosis and different treatment and give the side effects, right? So when do you want to do this? What are the places where you will be picking up the patients? So there are two methods to do opportunistic screening. So you can imagine the problem, magnitude of the problem. So it has to be done. It is a responsibility of every doctor to measure the blood pressure of their patient whenever they come. So they may be coming for the headache, they can be for the fever, small thing, right? Small cut, that blood pressure has to be checked at all encounters. And even young patients. So those who have high risk conditions like what Dr. Katulanda was telling, obese, and especially the women who had adverse pregnancy problems has to be measured yearly, regularly. You get them down and do it. And what do you do in first encounter? So get the pressure according to the standards in both arms, right? You have to measure in the both arms. There is nothing. You can't measure in one hand and just say no, right? And if there's a difference, you can repeat it and get from that onward, you should tell that person, this is get your blood pressure checked in the right hand or left hand. So patient will know and document it. So at the first encounter, if the blood pressure is lower than 130/85, right? You don't have to worry much, right? And if you provided that you have done it properly and with a proper instrument. If it is higher, and you have to take 2 more readings at the same setting, right? And 1 minute apart, discard the first one and average the last 2 readings and document that. So in certain people, you can, but it is not making the diagnosis. You are just making the measurement and found it to be high. So how do you make this hypertension as a disease? It's a diagnosis. You have to give that diagnosis. You can't give it over same setting because you have huge implications. But in certain people, you have to give the diagnosis. You can establish the diagnosis on the same day. Who are those people? How do you find them? If the blood pressure is very high. So as I said, blood pressure is a biological variant. Your blood pressure will go up with whatever the stress you have. It might be your physical stress, psychological stress, or if you have some sort of hemodynamic stress, if you have pain. So patients coming and running to the place and having severe pain, some backache, and you measure the blood pressure, you don't have to worry, right? And you have to get them back again and measure the blood pressure because it's a normal phenomena. And so if that is excluded, and then if the blood pressure is very high, you have to go through and find out whether they have evidence of acute hypertension mediated organ damage. Very important things, whether they are in impending danger of encephalopathy and retinopathy of asking about blurred vision, whether they are going to have a heart attack, ask about the chest pain, are they going to heart failure, and also having 6 P's about pheochromocytoma, and do a fundoscopy, And if they are not there, if they are there, you have to refer same day admission, admit that patient, right? And admit that patient and refer to the hospital. And you can't, if you don't have that high blood pressure, they might be going around. And then you have to arrange further repeat assessment and also to see whether there is high risk. And how do you do those kind of patients, you remeasure in a separate day. And so at least you have to get them down 2 more times to the office and 1 to 4 weeks apart. And so you do that, and same thing you do, same cycle. And still, if you can't, if you are not sure, you arrange this out of hospital measurements, and so assess for the hypertension mediated damage and risk. So who are these high risk? If a patient, you take the history, whether he has had heart attacks, whether he had a stent and stroke and intermittent claudication, and whether there is already known patient with CKD. And so this large number of patients who are diabetes are either, only few of them are, I think diabetic populations are having low or moderate cardiac risk. Most of them are having high, very high risk. So most of the diabetic belong to that. And if you don't have any of those 4 or 5 things, you depend on a risk calculator. What we have is Europe has got score 2 calculation, and Framingham, US has. We use the WHO one. And so then how to look for the hypertension mediated organ damage. So clinically you can do it by looking at the pulse pressure, and ECG has to be done in all the patients. And other situation is looking for the albuminuria and looking for the albumin creatine ratio and EGFR. We can't do them in all the patients in our setting, at least urine dipstick. And fundoscopy need not to be done in all the patients, only in patients who are having a grade 2, grade 3 high grade hypertension. So so as I said, it is mainly office-based or clinic-based management. So there are definite care pathways. As I said before, just if you don't have severe hypertension, so so you can review. And so it is intermediate, right, early, and you can confirm it out of blood pressure measurements that they suggest, or repeat. If you can't do it, not available, you can repeat, get them down to the clinic. And so if it is fairly high, you just confirm. And if it is over 180, 110, the diagnosis is confirmed. And that allows you don't waste time. You get on with the immediate drug treatment and get them back to 2 to 4 weeks. So this is how the diagnosis is made. These are the threshold values as they stand today, and 140 and 90. And home values are, at home it is 5 less. And when it comes to the ambulatory, it is about 10 less. And that you take as a 24-hour average. And so this is widely prevalent. You should know how to use the home blood pressure meter. And they are also same situation, you seated, properly seated, same as what I have told that in picture. And see, not easy, avoid caffeine, smoking, alcohol, right? And if you want to diagnose for the first time, you have to do it in 7 consecutive days. And you know, same duplicate measurement, 2 measurements. And so within very early in the morning, maybe preferably first thing in the morning after going to the toilet and emptying the bladder. And before, you know, taking the medicine or taking your tea, otherwise, because that will alter. And so they and take 3 measurements, 1 minute apart, and average the last 2. If this is for the diagnosis, this is not for the follow-up. And what about this ambulatory blood pressure? That measures the blood pressure throughout. That is very important, because you don't worry about the posture. It can be seated, you might be lying down, you might be sleeping, and any environment, not in the, you know, seated for 5 minutes, that kind of thing, where you might be at your work, and you might be at a hobby, and you might be going to the shop and or office, right? That is the importance in that. It records the blood pressure every 20 minutes. That is a new thing. At least 21 recordings, 14 in daytime, awake time, and 7 in sleep time. So importance is there are, even as I said, when you come to the diagnosis, first thing you can establish, if you use the both things, you can identify 4 different phenotypes of hypertension. So if the office pressure and the out of office pressure both are high, that is called sustained hypertension, and both are normal, that is called normotension. And this is if they don't have high pressure, recorded high pressure at your clinic, but at home it is there, that is masked, it is not evident to you. And the other opposite is that if you have normal pressure at home, but very high pressures at beyond the threshold is white coat. And this is very important. Why? Because the two phenotypes have 4 different prognoses. If you can see masked hypertension, they do worse. So that is the people who are difficult to diagnose. And whereas white coat may be fairly lower than the uncontrolled, but you have to be on lookout because they can develop hypertension and they can develop, some of them can develop hypertension-mediated organ damage. So the importance of doing this home blood pressure at the time of diagnosis, where you put a label, because you should not over-treat patients, right? Because these drugs are having side effects. For males, that gives the erectile dysfunction. So that is the game is over for his reproductive life and pleasures of sexual life. So they also the very high prevalence of erectile dysfunction for men. So you should not overeat, right? And so you have to do a diagnose white coat hypertension and not to treat, right? You don't need treatment for white coat hypertension. And also do not, you can't miss mask hypertension, because if you don't treat, it's worse than being diagnosed with office blood pressure. So this is also effect. There is a condition called treated patients, so you can have uncontrolled white coat effect and also uncontrolled mask hypertension. So these they have the very good control at your records in the office, but some of them are having uncontrolled blood pressure at home. So those are the uncontrolled mask hypertension. So that is one thing. At the time of diagnosis, the first thing you have to do, if you can do, make it phenotype. And number 2, you grade the diagnosis according to what you have found in the office, right? I think this has been, this is what has been done. So according to the figure that we got by averaging, and you put them at the grade, you can't do it later. It's at the time of diagnosis, right? And so as I said, you can say optimal, normal, high normal, and this as it stands, cutoff is 140 and 90 for diastolic pressure. And third thing you have to do is the stage at the time of diagnosis. So stage is to see whether they have hypertension-mediated organ damage, whether they have CVD, CKD, and diabetes. Four factors, and if they have with blood pressure, one of the four, you can diagnose. You can stage the hypertension as stage 1 and 2. Why do you want to do that? The cardiovascular risk, because all the time, even when you manage the diabetes, when you manage the hypertension, nowadays the people, the science, the experts want you to show that you can get benefit from you won't have a lot of heart attacks. You will prevent stroke and heart attacks by your intervention. Otherwise, they won't allow those drugs come into most of the time, especially in diabetes. And that is the situation will come to the even hypertension, because you can grade using the level. Grade is using the level of the blood pressure at the time of diagnosis, stage by the presence of other risk factors. You can categorize them into various cardiovascular risks. This risking is important because that not only tells about the blood pressure management, you have to manage their LDL level, back to various very low levels. You have to manage their blood sugars with new drugs, and that will improve the outcome. And so that those are the important thing. So then fourth thing, so you can't do everything, and you phenotype, stage, and assess risk, and you can't wait now, right? You have to do something, right? What can you do about them? So, and you have to tell the patient that you have a diagnosis and what to do. So what is important is what I have been telling about therapeutic lifestyle change. That you have been living with your own behavior, lifestyle. Now you have to change it as a therapy, not as as a treatment, because now you are a patient and it will be helpful for all. So That is even in grade 1 hypertension, who are in stage 1, who doesn't have, you know, mediated damage and high variability, you can give a trial of lipid lifestyle changes about 3 to 6 months. You don't need it in a hurry. But others, if it is grade 1, grade 2 or 3, and grade 1 is high risk and grade 1 with immediate damage, you should start drugs immediately, because they have been shown that they will help that kind of patients. And there are an age criteria also. Then what can you do, what can you advise? And as Dr. Katulanda was saying, weight is an important determinant. That's how. Then sodium restriction, very low sodium. This has been trial proven, and about 1 teaspoon allowed for a day. And dietary patterns, very important. They talk about, now they don't talk about specific food items, they talk about overall pattern of a person, what they eat. And especially it has been shown that evidence-based dietary patterns are those Mediterranean countries. And also US, they did a strict dietary pattern called DASH diet, the dietary intervention to stop hypertension. Those are the two main patterns of drug diets that has been shown, and most of those are plant-based diets, right? And animal-based diets are not so good. And I was told that physical activity had to be increased, but stress is upon to reduce the sedentary time. So sedentary time is when we become secondary, when we sit, when we lie flat, when we recline. So we use only 1 METs of energy during those time, 1.5 and less than, right? But we stand. If we stand, we are not sedentary. So that's why all these Western countries, hotels, banks, they don't provide for the employees the seat. They take it away, right? And so I experienced that even HSBC here, and had to do the thing with the standing, right? And so sedentary time. Then this regular structures exercise, you don't have time to do that. We don't have time. So there's a structures procedures. So you just walk, right? And stand, at least walk, right? That will help a lot as far as the. So what about alcohol? Now they were going away from allowing allowance of moderation, and they want to work towards total abstinence, the science experts. And smoking cessation has to be absolutely done, and you should not be exposed to any kind of second-hand smoking or third-hand smoking or e-cigarettes. E-cigarettes themselves they don't have all the bad effect, but they have the nicotine plus other combustible vapors which will damage your endothelium and give atherosclerosis. And so stress management, now they are talking about how to be mindful, right? And not proven yet, they can't prove yet. They can read, they can touch the mind, they can quantify the mind, so what they suggest, and about the meditation, right? And this is one of the very important things, that sound and air pollution, both have implications, hypertension and atherosclerotic cardiovascular disease. And so hypertension is the first global cause for mortality, risk factor, then smoking, then comes the unhealthy diet, and fourth comes the air pollution. So why the people who die, anybody dying in this world, they are exposed to these risk factors. So thing that we can do at the same assessment, there are certain drugs, simple things, because I'm not going to touch about the secondary part. And you should, this hypertension, diagnosis hypertension can be done at home. Right now it's like, because these measures are available in home. And you can, if a patient has, if you sit into the person in the next door, you can measure, have an idea. So there's a concept of democratization of the healthcare in the globally, because you empower the people who are even non-medical people to deal with their disease, diagnosed. So, but you should know as doctors or healthcare workers when to refer for specialist care. These are some of the things. And so we have now diagnosed, and we have done a lot of things, and but we should know what are the safe targets, right? These are given from the epidemiological studies about systolic and diastolic pressures. They are J-shaped curves. Even if you lower systolic pressure less than 115 and diastolic pressure less than 70, you get increased mortality. And they have found, the scientists have found the sweet spot to land, right? And these are the sweet spots. And so you should never go beyond, when you're treating the people, you might get people, as I said, lower, normal people who are walking around who have not been come to, but having a blood pressure of 100/70, and they are okay because that is a normal distribution. If you want to reduce the high blood pressure patient and treat by treatment, you should never go beyond 120 or 70. And always do it as a range. You can't give one value because it's already variable. You have to tell 120. First you start with 140/90, then come to 130/80, then come to 120/70 range, because you can't do it overnight. It has to be patient. Otherwise, patient will get the side effects and discontinue that and never want to have it. And so give it gradually. And so, an important thing is it's a long-term affair, as I said, lifelong affair. So with drugs, so what we need is to minimize the blood pressure variation. These kind of people have various abnormal patterns of blood pressure variation. Usually our blood pressure falls at sleep, and that dips, and there are certain, some people it dips very more, and some people it rise, right? That nocturnal hypertension and dippers, abnormal dippers. And in the early hours in the morning, some of us get high blood pressure. That's why early hours of the morning, that's a natural phenomenon, we get heart attacks, right? People come in the early hours in the morning, more with the, acute events. So early morning surge, if it is more than 40, that is bad. And those can be measured in this our ambulatory BP. So variation has to be within the acceptable levels. And so we have to, now the concepts are, when it comes to this is available, now it's been applied in the warfarin. You talk about INR, time taken within the therapeutic range. The similar concept is coming to the blood pressure. So time in therapeutic range, it has more value. And main problem is making the consistency is the problem with the clinician and problem with the patient. Patient don't adhere to what you say, and clinician don't mind, they say the pressure is 160, 100, don't worry, come next time, they come next time 6 months later. That is clinician inertia, and patient non-adherence is the main challenges. And when it comes to the drug therapy, there are 4 different classes, and they usually have complementary actions, and if you give one drug will add upon to the action of the others. They are complementary most of the time, especially these 3 classes of drugs, and they are being combined. Most of the time you give it in combination, not singly, and combination is done in a single pill so that it's easy for the patient to comply, right? That is the concept. You give a single pill with drug combination which are in complementary. Out of until recently, until this document, beta blockers were put it to the side. And because of previous trials done with the drug called atenolol, they have showed adverse effects and put the whole class of beta blockers into disrepute. Just atenolol being used. But that is one bad person in the beta blocker group, all the other fellows are good. And when they put the trials, and they found that beta blockers are not so bad. Because the simple practice, as I said, what is most important is the central aortic blood pressure. Atenolol does not reduce the central arterial aortic blood pressure. So it just, you didn't have the beneficial effects. So that's how it works, and you can combine and drugs and so effective. These drugs should be effective and they should be safe. And so the safety comes first, right? You don't want to symptomatically give a drug and for them to have allergy and die immediately, right? And that is the safety, any intervention. Then comes the effectiveness. Then long-term affairs, they should be able to tolerate, otherwise they won't take. How safe, how effective, they won't take. If they have gastritis or something, they will omit it, right? And but you can, as Western medicine practitioners, we have to always depend on the evidence. So when it comes to the drugs also, these are the drugs that have been shown in clinical trials to be used in patients with hypertension, and we have various good properties, right? And as I said, 24-hour control, you should not have more, you should cut off the early morning blood pressure surge where you can get MI, and nocturnal blood pressure should not be high, that is very bad. And because night, all the systems should go down and sleep and repair, right? And so these are the things. When it comes to the International Society of Hypertension, as I said before, they categorize essential and optimal. Optimal are not for us, they are for high high resource settings, they have money, their countries have high, not the people, country should have money, otherwise they can't bring these blood pressure meters and things. So in countries like us, because our country doesn't have money, we have money, but country doesn't have, therefore everybody can't get that. So these are the essential criteria. They talk about sequencing the drugs in combination, right? How to sequence and come to the triple combination. And the resistant, if they are not controlled, even with a diuretic with 3 drugs, then you call it resistant. I'm not going to talk about it. So principles of drug therapy or any treatment, you have to tailor to the patient needs. Patient has the right to say, no, I have very high blood pressure, you will die next moment. He can say, no, I don't want that, right? So you have to just say it's a patient-centered, this drug I don't want, right? So that you have to accept, right? That patient's right. And so one very important thing is your drug should be safe for the childbearing age, because you can't sacrifice the next generation to prevent this generation, right? Okay, because you have to keep the next generation healthy, because human race will evolve for the better. It has evolved from the time of the cave we have been living millions of years ago. Now we are going to the spacecraft. So our children, grandchildren will go out of the solar system. You have to keep them healthy. So you can't, if you can't give teratogenic effect to the woman, you have to be very sensitive. These young ladies who have a potential to have a pregnancy are being given these drugs. So this should not be the case. And so there are safe drugs which can be given. So omit this drug. So all this, you don't hesitate to, there are safe other drugs, right? If you see them in a childbearing age, omit it. Just, even he might be 48, still woman can get pregnant, right? And when I said that when you choose the drugs, long-acting drugs without giving variation, so these are the best drugs, telmisartan, amlodipine, right? And that combination works very well for this one. Whatever you give, if you are not giving free to the like our state sector here, and it has to be affordable. And if you see in the out of market, there are about, I know about few drugs, especially the statins, right? And so there are drugs for few rupees to, 500 rupees, right? That is the problem with our country. You allow to flood the market with hundreds of drugs rather than identifying a good 4 drugs where you can cover the whole range. So we also don't know, and we write something, and pharmacy fellow gives what he wants and what he been incented to deliver, dispense, right? And so the drug has to be well tolerated. And so this is another concept, chronotherapeutic regime. Right, as I said, when you give a drug, it has to be 24-hour control. Night pressure has to be within this range, and it can't go up. And early morning surge should be less than 40. And morning, when you measure the home pressure, it has to be below 130/80. Right, if you have a meet at home. So if you are giving a single drug regime, better to give it in the morning, right? And okay, fixed time, either in the morning or either in the morning, preferably in the morning. And if you are giving 2 drugs, and so better you can, the CCBs and diuretics, better control for the daytime, and evening, RS blockers and beta blockers. So that will control the morning surge. All those are very important, right? So what I have been telling, if I am to summarize, so it's about diagnosis, it's repeated blood pressure measurement at the clinic, but out of pressure measurements are useful for day-to-day management, sometimes for the diagnosis. So you have to have, each person has to have a personalized approach. They will have various side effects, various comorbidities, and whatever it is your duty to prescribe rationally. And make sure that you give the drugs in a single pill, so that patient likely to not to miss that doses, and low cost, otherwise they won't buy your long list, they won't buy anything, right? And they go to these days very expensive drugs, right? People spend our prescription about 30,000 rupees per month. Because our drug list have 14 hypertension, lipids, and 3 drugs for each, right? And each condition, and so less side effects, and ensure the compliance. So make sure that you don't treat the blood pressure numbers. You have to treat the patient. He might be having various problems at home, problems at the workplace, and can't come to the clinic, right? What to do? They can't, then they come to our private sector because they are employed, right? and they wait for us, and rain is gone, right? The pressure is high already, right? And that kind of things we have to be aware, and so treat the patient, not the numbers. So thank you very much.
Thank you very much, Dr. Anidhu, for this comprehensive and informative lecture on management and evaluation of essential hypertension. And now the organizers are ready to entertain a Q&A session of about 5 minutes regarding the 2 lectures that we had today. Prof. Prasad Katulanda and Dr. Anidhu is more than happy to answer any and all questions that the audience is having regarding their respective lectures. So the audience is requested and encouraged to ask all questions and any and all questions that they have got. If you get any questions, please raise your hand.
We have Dr. Anindhu as well as you have Priyanka, who is expert on pharmacological management of hypertension. So we have a lot of medical students and junior doctors in the audience. What sort of medications we should start and then titrate, and can you give some guidance on initiation and escalation of antihypertensive therapy?
Priyanka also can tell. I think it's for diabetic, I think it's ACE inhibitors, right? No? So others, it depends on the cardiovascular risk. If you have diabetes, if you have diabetes, it's ACE inhibitor, it's the first choice, unless there are contraindications. So others, it depends on the age, right? And age, if you are old, more than 50 years, and the CCBs are best. And so irrespective of the cardiovascular risk, if they have cardiovascular risk also, ACE inhibitors. So other combinations that works very well with the ACE inhibitors, and that group, if you combine with the diuretics, that works very well. And also CCB's combination, that works very well. So whatever you give, third drug should be diuretic. I mean, otherwise you will just fall into the resistant, you will be calling inappropriately resistant hypertension. You give 3 drugs other than including the diuretic and patient not control, you can't call it resistant hypertension. Third drug should be a diuretic. So beta blockers have specific phase in very common because this blood pressure puts hemodynamic load onto your system, arterial vascular bed. So hemodynamic load, that is not on blood pressure is not only the hemodynamic attribute, heart rate is also important. So all these blood pressure guidelines, very one less sentence, consider the heart rate, control the heart rate. So control the heart rate. If it is high, beta blockers, unless they are contraindications. If it is contraindication, so non-dihydropyridine calcium channel blockers. So that's how you can tackle both together.
agree with what Sir said, but the only thing that needs to be remembered is, these guidelines and sort of things do specify the best choice, but at the end of the day, what we have to remember is the control is the important thing. There are studies showing that the people are put on drugs, and majority of the patients, maybe about 50% at the end of 1 year, they are not on treatment. So the most important thing is to regularly monitor and make sure that they are on appropriate therapy, including appropriate escalation by combining medicines, and ensure they take medicines and monitor the blood pressure.
So if it is more than 50 years, we would go for calcium channel blockers, and less than 50, what is the better choice? ACE inhibitors. Okay.
So European guidelines we like because one reason is it's very close to, they're not like American guideline, very skewed, very difficult to practice. You need a lot of resources, and European, other thing, we have affiliated our college with the European Society of Cardiology. We can directly adopt there without their guidelines here. So last few years we have been, directly, even COVID time, we just adopted their cardiovascular guidelines. So one other thing, and one important thing I wanted to mention about the women getting, Dr. Mahipal was saying women is living 5 years longer than men and whatever it is, but still we want to make the gap longer, right? And so by preventing their cardiovascular disease, less risk. One very important cardiovascular risk factor, novel cardiovascular risk factor like air pollution, is disorders of blood pressure and blood sugar in or even any bad obstetric event within their pregnancy. That is a very high risk, that adds a lot of high risk to the pregnant woman, and so that we have embarked this LCC and with the NC Family Health Bureau, and to devise a program, island-wide program, to detect this, not only blood pressure, their blood sugar and lipids level at various levels in a systematic manner when they come to when they bring the patient, their child to the vaccination, because they won't come, right? They will come bring the child to the vaccination clinic, otherwise they will be busy with the child. So that has been underway, that with any patient who had mother who had bad obstetric history, we thought of devising a method to do systematic screening for blood pressure, blood sugar, weight, and cholesterol. So that is been done. Thank you.
We can make it for another 1 minute to entertain more questions. If the audience have got any questions, please feel free to ask. The resource persons are very willing to answer your questions. It seems that there are no questions from the audience, so we are moving on with the formal schedule. So next up is a lecture on management of hypertension in diabetes, and that will be conducted by Dr. Niranjala Migodavidanage, consultant endocrinologist, Colombo South Teaching Hospital. Madam, the stage is all yours.
Good morning, everybody. It's a pleasure to be part of this World Hypertension Day program. I would like to thank Professor Prasad Katulanda for inviting me to deliver this speech. I'm impressed to see that it's not only the doctors, but nurses, matrons, and all the other healthcare workers are here, because these are non-communicable diseases we are talking about. So it's not only the doctor's duty. Most of the patients first see the nurses, first they talk to the nurses, the matrons, other healthcare workers, get their opinion, and they talk to the medical students, and then only they will talk to a doctor sometimes. So it's very important to disseminate the knowledge with all the healthcare workers. So that has been planned today, so I'm happy to see the audience. So my topic is management of hypertension in diabetes, and you may have heard a lot about epidemiology. That, to recap, few things I would like to mention. There are some epidemiological studies done in Sri Lanka also. Like they have found that the prevalence of hypertension is about 40% in adults. So that is a very high prevalence rate, even more than diabetes. We know among about 27% of our adults in urban and suburban areas have diabetes, but mind you, the prevalence of hypertension is even more higher. And apart from that, it's almost double the prevalence of hypertension among diabetics. According to certain US studies, they have found that about 60 to 75% of their diabetics have hypertension. So it's a very high prevalence. And hypertension is a major risk factor for atherosclerotic cardiovascular disease, heart failure, and other micro and macrovascular complications seen in diabetes, including nephropathy, retinopathy, neuropathy, and so on. So what is the pathophysiology? There are a few things that I don't want to bombard you with a lot of details, but there are some, to simplify, there are a few things that we know that our diabetic population is obese, some of them, most of our women are obese. And even if they are not obese externally, there is increased visceral adiposity. They have more fat deposition in their organs inside the body, which will lead to chronic low-grade inflammation. And with that, they will have activation of renin-angiotensin system. So they will have increased angiotensinogen, and which will get converted to angiotensin 2. We know that it can cause increased blood pressure. Apart from that, when the diabetic patients, they have insulin resistance or insulin deficiency, we know, when they have insulin resistance, it is associated with increased vascular adhesion molecule expression, oxidative stress, ongoing inflammation, and decreased vascular nitric oxide. We know this nitric oxide inside the vessel, which is produced by the endothelial cells, is important vasodilator. So that is lacking in diabetics, which will lead to vascular stiffness and to chronically elevated blood pressure. When the vessels are stiff with the blood pressure, they cannot expand, though the pressure will be high. So those are the main reasons why a diabetic will have a high blood. So those are the main reasons why a diabetic will have a high blood pressure. So there are some features which are different from a non-diabetic when they have the high blood pressure. So they have greater systolic blood pressure elevation when compared with the diastolic blood pressure elevation. Therefore, they have a wider pulse pressure. We know the pulse pressure means, what is pulse pressure? The difference between the systolic and the diastolic. And they have a high blood pressure variability. Usually during the daytime, there will be a subtle blood pressure variability, about 20 millimeters mercury of systolic and 10 millimeters mercury of diastolic. But diabetic patients have a higher variability, maybe more than that, maybe less than that at times. And there is another condition called non-dipping pattern. Usually blood pressure, when we wake up, it will start rising. And during daytime, up to about noon, it will start going up. Then towards the latter part of the evening, the blood pressure will start dipping or dropping down. And in the night, the blood pressure, what we have expected, is usually about 20 millimeters mercury less than the morning blood pressure, systolic blood pressure, and about 10 millimeter less than the diastolic blood pressure. That means if a person is having about, let's say 140 in the 140, 90 in the morning, towards night it may be 120 by 80. So this is called dipping pattern. So in diabetics, this pattern is not seen. So we call it non-dipping pattern. And apart from that, they are more sensitive to salt, the diabetics, for many mechanisms, sometimes not well understood, but they have some kind of a hypersensitivity for salt. Therefore, even if a non-diabetic takes same amount of salt, if the diabetic patient takes the same amount of salt, still their body will respond more and their blood pressure will rise more than what we expect. And they have a trend to develop hyperkalemia for many reasons. When they have nephropathy, they will retain potassium. And when they have insulin deficiency or insulin resistance, they may become a bit acidotic. You know, the diabetic patients have a higher tendency to become acidotic. So what will happen, the body will, in response to reduce the acidosis, they will get rid of the hydrogen ions and they will absorb potassium. So their potassium will go up. And apart from that, they will have glycogenolysis. That will also produce potassium. So they will have high potassium levels. And they can have orthostatic hypotension. when they are standing from sitting position, sometimes they may develop hypotension. Because with ongoing long-standing hypertension, they will have their autonomic nerves neuropathy. Autonomic neuropathy, that is dysfunction of their autonomic nervous system. Therefore, they will have orthostatic hypertension. And they have a high prevalence of masked hypertension. What is masked hypertension? Usually when they see a doctor, when they are excited, when they are tired, or when they are a bit scared, you call it white coat hypertension in past. So they will have high blood pressure when they see the doctor. But there are some, in diabetics, some patients, they have normal blood pressure at doctor's chamber. But when they measure at home, their blood pressure may rise. In the night, they may have high blood pressure. So they may come and complain, doctor, now the blood pressure is normal, but when I monitor at home, my blood pressure is high. Or else the patient will have very good blood pressure control, but the patient will continue to have complications like the ongoing heart failure, developing ischemic heart disease, worsening nephropathy, kind of complications. Then you have to suspect whether this patient is having masked hypertension. And diabetics have a higher rate of resistant hypertension. You may have heard of a lot about resistant hypertension in the morning. So what is the evidence? What are the evidence to say by controlling blood pressure you can achieve a better health? So you know this, the Hypertension Day theme is measure your blood pressure accurately, control and live long. So that is the theme for 2024. So how do we live long? So this UKPDS is a landmark trial in diabetes that was done in UK, and the results were released in 1998. That is the largest study including type 2 diabetics. So they also had a hypertension arm. So what they tried is they had two arms. One arm they had a tighter blood pressure control, targeting at the blood pressure reduction to 150, 85. And the less tighter control group had the blood pressure of less than 180, 105. So what they have found is just by the reduction of 10 millimeters mercury systolic blood pressure, they could achieve a greater reduction of all diabetes-related complications, like about 12% reduction of the risk of any diabetes-related complication, 15% reduction in deaths related to diabetes, and 11% reduction in myocardial infarction, and 13% reduction in microvascular complications, that is nephropathy and retinopathy. So there is a greater benefit by lowering blood pressure. There is another trial called ADVANCE trial. That trial enrolled about more than 10,000 patients, that is about 11,140. And they assigned one group to perindopyl indapamide combination tablet and the other group placebo. So that is blood pressure lowering drug. But there was only a modest reduction of blood pressure in the treated group. That is about 5.6 millimeters mercury systolic reduction and 2.2 diastolic pressure reduction. But what was the outcome? They found that there is a greater benefit. There is a significant benefit for the combined primary outcomes in diabetes. And down the line, even after 6 years after completion of this trial, they still found that there is benefits with respect to mortality for the patients who receive this combination therapy. So there is another study called a CODE study. Again, that study, they had an intensive therapy targeting the systolic blood pressure to less than 120, or the standard therapy targeting systolic blood pressure to less than 140. And they found that there is a significant reduction of non-fatal strokes in patients who were treated tightly. And this is a meta-analysis of all the blood pressure controlling studies among diabetics to see what sort of benefits they will have. So you will see that there are, all these studies favored the blood pressure lowering. All the studies favored the blood pressure lowering. And apart from that, there was significant, very significant outcome, beneficial outcome for the patients with when it comes to the cardiac mortality, cardiovascular disease, coronary artery disease, and reduction of albuminuria. All these things were significantly improved with blood pressure lowering. So what are the benefits of blood pressure control? As I told you, reduction of mortality, reduction of macrovascular, microvascular complications, mainly nephropathy and retinopathy. So how do we diagnose? So you all have listened to many lectures from the morning, and you know blood pressure targets for general population, but I am talking specifically about the diabetic patients. So how do we diagnose hypertension? So there are many schools of thoughts. There are subtle differences, but generally systolic blood pressure less than 130 and diastolic blood pressure less than 80. Based on, it's not more than, it's less than 80. And we can't go by a single reading. We have to do at least 2 separate readings in 2 separate occasions to diagnose hypertension. So these are the blood pressure targets, and there are several international guidelines. ADA, that is the latest updated guideline, ADA guideline, American Diabetes Association, recommends blood pressure targets of less than 130/80 for a diabetic patient. And American Heart Association, AHA, that also endorses that, and their also goal is to have the blood pressure less than 130/80. So this is all about diabetic patients with hypertension, mind you. And our college, Sri Lanka College of Endocrinologists, also have made our own guidelines, and our aim is also for those who have high cardiovascular risk to have their blood pressure less than 130/80. And for those who have lower cardiovascular risk or older adults where there may be some other problems associated with too much lowering of blood pressure, for their goal is less than 140/90. And European Association for Cardiology, that is ESC, they also recommend the systolic blood pressure for less than 130, but they do not recommend reduction to less than 120 because of associated some increased morbidity and mortality. And for the older adults, they recommend having the systolic blood pressure between 130 to 139. And International Society for Hypertension, that guideline also recommends lowering blood pressure to less than 140/90. If the patient can tolerate, it's always better to go for lower targets like less than 130/80. So the AACE, American Association for Clinical Endocrinologists, they also recommend less than 130/80, but in the presence of complications related to macrovascular complications, that is having macroalbuminuria, moderate to high risk of cardiovascular disease, presence of retinopathy, whenever possible, in possible patients, they recommend lowering blood pressure to less than 120/70. So this is the ADA guideline. So I will take you through this guideline carefully. Then you will understand very well, because this is a very simplified, easy to understand, though it looks at a glance complicated. So the entry blood pressure in a diabetic, I'm talking, systolic 130 to 90, diastolic 80 to 9, systolic 130 to 150, diastolic 80 to 90. So that is the initial, this left part of the part that I'm going to discuss, that part. So the recommendation is to go for a single agent, monotherapy. If the systolic blood pressure is between 130 to 150, diastolic between 80 to 90, go for monotherapy. So the lifestyle management, I heard Dr. Anidut speaking about it. So it's equally important in every stage, even if they have very high blood pressure or modestly elevated blood pressure. So for the lifestyle management, cutting down the salt, increase physical activities, having adequate sleep, and cessation of smoking, cutting down alcohol, and these things are very important. And maintaining healthy weight, equally important, for the which comes under the lifestyle management. So when they, now as I started at the very beginning, so the blood pressure systolic modestly high, that is 130 to 150, diastolic 80 to 90, you go for monotherapy. So what is the agent? Deciding on what agent to use will depend on few factors. So if they have microalbuminuria or coronary artery disease, then the first agent should be a ACE inhibitor or a angiotensin receptor blocker, ACE inhibitor or a ARB. That will be our first choice. But if the patient does not have any albuminuria or coronary artery disease, we have 3 agents. Out of these 3 agents, we can choose any. That is a ACE inhibitor or ARB. We are not going to give ACE and ARB both. So ACE inhibitor or ARB, or a calcium channel blocker, or a diuretic. Out of these 3, we can choose any. So if the patient is having a satisfactory blood pressure control, if the goal is achieved, we can continue. And if the patient is, while on a ACE inhibitor or ARB. Now we are starting monotherapy for modestly elevated blood pressure. So if their blood pressure has not achieved the goal, then we have to choose another agent. Now ACE or ARB we have chosen already. So out of the other two, CCB, calcium channel blocker, or a diuretic, you can choose any of those two agents as the second line. That is if the patient has not achieved the goal or if the patient has intolerance to the medication that we use. Usually we know that ACE inhibitors are associated with dry cough, which is notorious. Unless you discontinue the treatment, the condition will remain. Then otherwise, like the calcium channel blockers, sometimes they may get angioedema. So you may have to discontinue. So in such scenarios, also you can choose any other agent for the blood pressure control. And if their blood pressure control is not yet achieved, then we can move on to the next stage. So we can use aldosterone, mineralocorticoid receptor antagonists like spironolactone or eplerenone, or else in tertiary care setting, you can always refer the patient to a tertiary care setting where the blood pressure is not under control with your initial management. So what about the patients who have, now that I have finished this part, left part, where the patient is presenting with the initial blood pressure of 130 to 150 systolic, 80 to 90 diastolic, that is moderately elevated blood pressure. What about the patients who are coming with very high blood pressure, or if their blood pressure is more than 150? Lifestyle management is equally important. Apart from that, you have to go for dual therapy. That is the recommendation by the ADA revised latest guidelines. So you start with 2 agents. So what are the 2 agents and how are you going to choose on? Again, presence or absence of albuminuria or coronary artery disease is very important here. If they have albuminuria or coronary artery disease, you always choose ACE inhibitor or ARB. That is a must. And as the second line, you can use a calcium channel blocker or a diuretic. And if the patient is not having albuminuria or coronary artery disease, you can choose any 2 agents of these 3 drugs, 3 groups of drugs, ACE or ARB as one of those 2 drugs, calcium channel blocker, a diuretic. Out of 3, you can choose any 2 if the patient is not having coronary artery disease or albuminuria. If the patient is not having a satisfactory control, or if the patient is having adverse effects, then from there onwards, it is similar. It is similar what we have used for the modest elevation of the blood pressure group. So you choose another agent from those 3, and if the patient is not having a satisfactory control, you move down. And if you cannot still control, then you may have to refer the patient to a specialist center. I hope I made that part clear. Okay, so this is the AACE guideline. Why I took this is to show you that there are few subtle differences. Basically, ADA and AACE guidelines are the same, but there are few differences which I would like to highlight here, where they are also the systolic and the blood pressure goal is less than 130/80 for the diabetics. But in the presence of micro macroalbuminuria, moderate to high risk of established atherosclerotic cardiovascular disease, peripheral vascular disease, retinopathy, and then they recommend lowering the blood pressure to less than 120/70 in a diabetic if the patient is tolerating. So, but for the patients, there are some categories of patients whom you cannot lower the blood pressure too much. For example, those who have orthostatic hypertension, those who have autonomic neuropathy, very old and frail patients, and when they have acute coronary syndrome, and the patients who refuse. Like Dr. Anindu said, the patient might decide, so I don't want to go for this drug, I don't like this drug. Then you cannot, because we have to always respect patients' autonomy. Otherwise, you can always lower the blood pressure to less than 120/70 if they have any additional risk factors and if the patient can tolerate. So lifestyle intervention is equally important. So this DASH and Mediterranean diet, I heard a few things were mentioned. Increase physical activity, achieve optimum weight, all these things are equally important when it comes to the lifestyle intervention. So the first line, according to the AACE guidelines, is also ARB or a ACE inhibitor. So you go for ARB or ACE inhibitor for patients who have initial blood pressure goals of less than 150, and you can, if it is more than 150, the presenting blood pressure is more than 150, like in the ADA guidelines, you go for dual therapy. So you start 2 agents in that scenario. And then you can titrate the medication, but when you are titrating also, you are not going to do it very, very quickly, because we have to wait and see whether the patient is responding. Then you monitor the blood pressure in 2 to 3 months, unless it is extremely high and may need more frequent monitoring. So if it is mild, moderate elevation, you wait for 2 to 3 months with one drug or 2 drugs, depending on the blood pressure that you have added at the beginning. Then you see the response. If the response is not adequate, you can move forward and start another drug. So the patient is already on ARB or a ACE inhibitor. So the patient is not having a satisfactory control. You monitor the patient in 2 to 3 months. Then you go for the next level. Then you start a thiazide diuretic, that is a diuretic, or a calcium channel blocker, similar to ADA guidelines. And if the patient is still not responding, you go for combined alpha-beta blockers, beta-selective blockers, mineralocorticoid receptor agonists, and there are so many after that. But anyway, up to this level, you can manage even in a primary care setting, and after that, the patient may need specialized care when we move forward with quite a resistant patient. Okay, so the lifestyle interventions, weight loss, as it was discussed before, with the caloric restriction in overweight and obese patients, because reduction of visceral adiposity or weight reduction by you losing weight, we actually get rid of our excess fat tissue, which is adiposity. So by that, you can prevent this ongoing, you can halt the ongoing chronic inflammatory changes inside your vasculature. So that is a very important thing to lose weight. And dietary approaches to stop hypertension, that is DASH diet, dietary approaches to stop hypertension. Style, I'll show you a picture of the DASH diet. And DASH diet includes low salt intake, that is less than 5 grams of salt per day per person, increased potassium containing food, restrict meals such as red meat, sugar containing sweets or beverages, and alcohol is best avoided. And if the person wants alcohol consumption, then maybe up to about 2 units per day for a male and 1 unit for a female. So that is the recommendation. But now the recommendations are also to totally stop alcohol, like smoking, and by increased physical activity, and advice on adequate sleep and stress management, which is equally important in hypertension. You may see that when the patient comes to the doctor, always the blood pressure is high. Patient brings home monitoring records most of the time. Quite all right, well under control. And their general practitioner will measure the blood pressure, which is quite all right. But when they see the specialist or when they come to the doctor's chamber, their blood pressure is always high. So stress has a major contributor for this elevation of blood pressure. Therefore, and the sleep deprivation is equally bad, very bad. It's a very bad habit to deprive your sleep. At least 6 hours of sleep is mandatory for a healthy adult, so which we all are lacking most of the time. Okay, this is a picture of a DASH diet, as I told you. So this is basically the Mediterranean diet that we all know of, and it encourages a lot of whole grain, vegetables, fruits, nuts, seeds, legumes, and those are ample. You can eat any amount, so it's very good if you use those food items. But the red meat, poultry, those things have to be in moderation, cutting down. And sweets, especially these ice creams, puddings, all these sweets, less than 5 servings per week, not per day. So that is per week. So other servings they say about for the day. And then the fats and oils, everything you have to cut down. Fat and oil and the meat, poultry, animal proteins, basically if you have to take under one umbrella term. Animal protein, all you have to reduce. But plant-based diet is the best, which we have been using for ages in our generations. So that is what now they are recommending even for diabetes. Mediterranean diet, and to lose weight also the Mediterranean diet is the best. So why we have to be cautious with the intensive blood pressure control? Because there are older patients who are very frail, feeble, they have orthostatic hypertension, and they have some functional limitations. So all these things will contribute to substantial increased morbidity and mortality if we try to lower their blood pressure too much. Therefore, when we have to be very careful when we are targeting a very low blood pressure goals for some patients. That is why for older patients, the recommendation is always to have their blood pressure around 140/90. Never to lower less than 120/70, because they may fall, they may fracture, there may be a lot of problems associated with too low blood pressure in elderly. So resistant hypertension, I don't think I have to deal with. And to conclude, I think there are a few, this is probably the last slide. So diabetic medicines, which have a blood pressure lowering effect worth mentioning. There are some newer groups of medications. You all know that GLP-1 receptor agonists are in the limelight. So that is one of the most attractive medications available for the blood pressure, blood glucose control. Especially there is a drug called semaglutide, you may have heard of, which is very good for the weight reduction. There is a very significant, like about 12 to 15 pounds of weight will be reduced immediately when you start this semaglutide drug. So maybe because of that weight reduction benefit, so that is associated with some blood pressure reduction as well. But unfortunately, this is a very costly drug. Because of that, it's only one drug is available in Sri Lanka, injectable preparation. So patients are a bit reluctant and cannot afford for most of our patients. But SGLT2 inhibitors, which we have been using over many years, which is again a very attractive option when it comes to the glycemic control plus blood pressure reduction. You may see that about 3.6 millimeters mercury of systolic blood pressure reduction and 1.7 millimeters mercury of diastolic blood pressure reduction is achieved with this blood glucose lowering medication, which is SGLT2 inhibitors. So the efficacy is almost comparable with low-dose diuretic like hydrochlorothiazide. If you use, that will be the blood pressure reduction that we expect. So that is a very good drug. So these two drugs that we have, classes of drugs that we have been using for blood glucose control has beneficial effects on the high blood pressure control as well. In summary, prevalence of hypertension among diabetic population is almost twice that of non-diabetic patients. Hypertension is a major risk factor for atherosclerotic cardiovascular disease, heart failure, other micro and macrovascular complications in diabetics. And controlling blood pressure is associated with reduction of many complications related to diabetes. You all have seen the evidence I have given from many landmark trials. And according to many guidelines, blood pressure goal of 130, less than 130/80, seems reasonable in diabetics. And ACE inhibitors and ARBs are the first-line agents to be given unless contraindicated, like Dr. Anandu mentioned, the women of childbearing age who are desiring pregnancy, we probably don't want to start them on ACE inhibitors or ARBs, but we have other options. And depending on the blood pressure response, we can use diuretics, calcium channel blockers, beta blockers, alpha blockers, mineralocorticoid receptor blockers. There are a lot of groups of medications to achieve the goal. So we have to avoid clinical inertia. The clinicians non-responding to patients' blood pressure elevation. So that is called inertia. So we are just neutral on whatever the patient is coming with. We have to always avoid that. Actively get involved in the blood pressure control in your diabetic patient, because that is going to prevent many micro and macrovascular complications in the future. Thank you very much.
Thank you, madam. If the audience is having any questions, you can raise them now.
Yeah, I think again for the benefit of the audience, and I think we have fairly a lot of experts on hypertension. Earlier, actually, when I think when we were medical students, there was fairly, a lot of focus on giving antihypertensive therapy at night. But now the focus is more to start in the morning. So, any thoughts, Priyanka or Anidu? Giving preferentially in the morning antihypertensives.
So I suppose, as I said earlier, the idea probably would be to get them to take the medicines at least optimally once daily. I mean, rather than forgetting and non-adherence, to sort of encourage them to take as much as possible. I know we are talking about long-term daily control, but given the problem of non-adherence and the patients, not a large portion not taking it, the emphasis should be to encourage them to take it, and I suppose taking in the morning is probably convenient for them as well. Sir may also want to add something to it.
So I think the concept is blood pressure variability, as I was telling, the variable, it can vary within the visit, right? Because you take the blood pressure now, it's very high, after 5 minutes it's down, right? That is bad, and it can be vary between visits. Next time you come to get him down next time, it is variable. And it can be vary between the visits, and visit to visit, between visits, and within the visits. And most of the time, as it's a biological variant, it responds to various needs of the body. And so naturally, it will be highly variable within the daytime. So if you can cut off that variability, minimize that variability, sometimes pressure might go up to 220 if you are angry with somebody, right? And it might remain, right? It might be at home also, right? So that variability, if you can cut off, that will have a effect. As I said, it is rather than they are finding the variability time during the control time, total time, rather than the blood pressure load. So I would say that if you are giving the drugs in the night, you have to give a drug that will cut off the morning surge. So that is not something that you have blood pressure that rises you after you have woken up. Just before you woken up, getting out of the sleep, because you are getting, your systems are getting ready for the day, your catecholamines and other things are being released. So that to cut off that, right? Okay.
Yeah, I think the thing is just some added thoughts. I think nowadays what I have seen is that when we give antihypertensives and a lot of patients, because of this so-called white coat effect, then when they go home, their blood pressure sometimes become too low, but nowadays there are so much of these digital devices which are actually, they are expensive for most people, but 5,000-6,000 for life-saving device which can be used for many years is not impossible for even fairly low-income people. And if we encourage this as a important thing that they should keep at home, I notice increasingly many people use so for people give a lot of presents for Mother's Day, Father's Day, they give expensive chocolates and all these things. Rather encourage these sort of things. I think as a way of life and habits, it can improve the quality of life and also the health of our older generation. Just some thoughts from myself.
Yes, I think that's a very good point, because most of our patients, when they come to our chamber, we see that they have very high blood pressure. So they give various excuses, and they say that their home monitoring had been always good. So I have actually come across many patients. I ask them to monitor at home and keep it documented and bring it along. So to the point, their blood pressure is always normal. So when they see us, their blood pressure shoots up. So I think in that scenario, actually, it's very useful to have a blood pressure monitoring device at home, so that even it will be useful for us to see whether the patient is truly having a normal blood pressure at home, so that we don't have to unnecessarily increase the blood pressure lowering agents.
Actually, to add to that, completely agree. I mean, at the end of the day, the ideal measure to check long-term control is to check 24 hours, which is not practical. And there are actually good studies showing that there is a good correlation between the ambulatory blood pressure and the home blood pressures, not the clinic blood pressures. So if we have a reasonable set of home readings, that will be a good way to sort of plan therapy.
So when you come to the current price also, we have been working on some thoughts of, and it's about 15,000 rupees, that good quality validated one that we used. So we were into a project, failed project to give that blood pressure meter to every, there are 8,000 midwives, and that was the initial thought, but the system, they don't want to be burden the midwives because they are, this message has to go not to the doorstep, it has to go from the door into the house, otherwise inside the home, these kind of messages and this type of simple interventions. So out of our, primary healthcare, the midwife's role is the most important role. That's how we, boast about our healthcare, even in Geneva, it's about midwife's role, and that's how we manage child health and maternal care. So we want to do that, but that failed. That's why we, improvise that to get the blood pressure meter at the center and measure at the center of the mother. Because if you can give a primary grassroots healthcare worker, maybe a midwife or maybe NCD worker, have a new post and give the blood pressure meter, then you take that home. It can the care can spill over. She will be measuring blood pressure in the out. If you have a blood pressure at home, you will be measuring blood. Then arch visits, then mage pressure එකක් මැනලා දෙන්න අල්ලපු ගෙදර එක්කෙනත් කියයි මගේ pressure මැනගන්න එනවා එතෙන්ට right. And at the same time I heard that ministry wants to give grama sevakers that role because this because so I don't know, there's some resistance, and so but as I said, the term is democratization of the healthcare. This can be if the your person can measure the blood pressure, you can taught them how to measure, why not grama sevaka? And so, but the concept being resisted.
Okay. Thank you for your inputs. So our next lecture will be delivered by Professor Priyanka Ranasinghe from Department of Pharmacology, Faculty of Medicine, University of Colombo. This will be on management of hypertensive emergencies.
Thank you very much. A very good morning to all of you. First of all, I must thank the organizers, Professor Prasad Katulanda, for inviting me to deliver this talk. I think these kind of sessions are quite important timed with the World Hypertension Day, not only to raise awareness among the public. Healthcare professionals also need to be aware about hypertension and the far-reaching implications of hypertension. So my topic is a bit of a technical one involved in acute management, but given the diversity of the audience, I will probably sort of not go into minute details, but since the students are also here, discuss concepts, but highlight the important principles involved in the management. So within the next few minutes, these are the questions I plan to answer in relation to the management of hypertensive emergencies, right? I'm sure you may have seen this entire, same exact figure previously, but why we are talking about hypertension at the end of the day is because it is a major problem, not only in Sri Lanka, but all around the world. It's a leading cardiovascular risk factor, and just to put things into context, a good comparator is the recent pandemic. Over the 3 years of the pandemic, all around the world, about 7 million people died, right? That is during the 3 years. But if you take hypertension and the complications or the adverse outcomes associated with hypertension, all around the world, about 10 million people die per year. So during those 3 years of COVID, 30 million people would have died from hypertension, no associated adverse outcomes, which means about 30,000 people per day, right? So it is a problem. And at the end of the day, hypertensive emergencies, as I will highlight to you, occurs due to either people not being detected initially or people not being on appropriate therapy at the end of the day, which then subsequently accelerates and goes on to develop acute target organ damage. So detection, appropriate treatment is probably the best way in the sense to prevent hypertensive emergencies also from happening. So the first question is, what exactly is an emergency? Now, in medicine, an emergency is something where unless you intervene within a short period of time, there is going to be adverse consequences. At the end of the day, the adverse consequences may be death, or the adverse consequences may be irreversible damage to organs leading to morbidity, right? So hypertensive emergency is a situation like that, right? Where it is not only the elevated blood pressure, but associated with the elevation of the blood pressure, there is a new onset or acute damage to what we call target organs, right? And unless you intervene, right, that is what we call an emergency, unless you intervene in an appropriate manner, in an appropriate period of time, there is going to be adverse outcomes. So what are these key targets organs that we talk about? It is the heart, the retina, the brain, the kidney, and the large arteries, like the aorta. So these are, I will talk about what exactly the damages that will happen. So there is a new onset acute damage to these organs manifesting in symptoms, which I will highlight to you, and that is associated with a very high blood pressure. At the end of the day, we do not emphasize on a particular value for a cutoff blood pressure, because some people with that high blood pressure may have normal organ function, whereas others will have acute target organ damage, but most of the time it is when the blood pressure is in stage 3 or above 180 or over 110 that these things start to happen. You may have, this diagram summarizes some of the manifestations. So in the brain, you can get encephalopathy, ischemic stroke, hemorrhage. In the heart, the acute pulmonary edema, coronary syndrome, aortic dissection, acute renal failure. These are some of the things that happen. You may, since students are also here, you may have also heard these terms: malignant hypertension, hypertensive encephalopathy, hypertensive urgency, which is a term that is going out of fashion a little bit. Since the students are also here, I will tell what these are. Malignant hypertension is basically like a subcategory, I suppose, where there is severe blood pressure that is associated with advanced changes in the retina, where you see papilledema and bilateral hemorrhages. I will show you a diagram of this. If you see this bilateral, it is highly specific if these changes are present bilaterally. And then encephalopathies, where you have severe hypertension associated with changes in the brain. You get seizures, cortical blindness. I will tell you why it is blindness, because of the area affected in the brain. And there is no alternative explanation for that. So you will understand it is for now to treat as an emergency. The first thing is you must recognize, right? For you to recognize, it is not only measuring and identifying the blood pressure is high, you need to recognize that there is an acute organ dysfunction in these organs, and that depends on a history, a proper examination, and also, most of all, also looking at appropriately timed urgent investigations, right? So this diagram, this highlights the different categories. I will not go into eclampsia or preeclampsia in pregnancy, but the other things that I also already mentioned. So it is about recognizing these things in the presence of high blood pressure. If these things are absent, earlier it was used to be called hypertensive urgency, but I mean that is something that is gradually, if you look at the recent guidelines, something that is gradually going out of fashion. Just basically there is no urgency in such cases. You need to get the blood pressure down, but if there is no acute organ damage, it's basically uncontrolled blood pressure. You start on treatment and monitor, but there is, as the term implies, there is no urgency as such. It is basically uncontrolled blood pressure. I suppose this diagram gives a better summary of things, of the different organs affected and the manifestations. It is coupled with, at the end of the day, a presence of very high blood pressure, right? And once this diagnosis is established, as I said, it is an emergency, which means then urgent treatment needs to be started, and there needs to be a rapid reduction in blood pressure, but that rapid reduction has to be controlled. Because at the end of the day, if you reduce it too fast to a too low level, that can lead to adverse consequences, as I will highlight to you. So it is a controlled but rapid reduction in blood pressure that you are targeting, which then makes it only possible for us to use a certain group of medicines that has certain pharmacological properties for the treatment of hypertensive emergencies. So the recognition of the target organ damage is not only important for diagnosis, but the target organ damage, which target organ is affected, is also important, because that will determine your subsequent management plan, the choice of therapy, how fast you are going to get down the blood pressure, what is the target blood pressure you want to achieve, and those kind of things are also determinant on identifying the target organ damage. So for two reasons, you clearly need to identify which main organ is affected. One is obviously for initial diagnosis, but subsequent management also is dependent upon appropriate recognition of the organ that is affected. Now, since the students are also here, I thought this is just one slide, not going into detail about pathophysiology. But what happens here is basically, now this does not happen overnight. As I mentioned to you, this is somebody who probably likely had hypertension for a long period of time. Due to various reasons, things accelerate, right? And when you have hypertension uncontrolled for a long time, one of the hypotheses is that the pressure-induced natriuresis leads to a vicious cycle where the RAS system is activated, the renin-angiotensin system, subsequently leading to increased vascular resistance, microcirculatory damage, and this then drives a vicious cycle where in individual organs, you know, the students know from physiology, that there is something called autoregulation, right, which maintains the organ perfusion. But when blood pressure goes very high up, this autoregulation fails, and then you start getting organ dysfunction. So this is the pathophysiology. But what I must highlight to you is this is not something that happens overnight. As I emphasized to you, this is somebody who had hypertension, diagnosed not taking treatment, or maybe secondary causes in some instances, but would have had undetected hypertension on the other hand. How common is actual hypertensive emergency? Unfortunately, we do not have data, local data available on this, but if you look at data coming from other countries, obviously given the acute nature of this will be detected in the emergency department, most patients will present there. It's about 1 in 200 referred patients with suspected hypertensive emergency. All of them don't end up being hypertensive emergencies. Some of them are just having high blood pressure without any target organ damage. About 1 in 2 of those will have hypertensive emergencies, and the common organs affected are the heart and the brain. But unfortunately, although mortality and outcomes have improved with knowledge, where people are started on appropriate treatment, the occurrence of hypertensive emergencies or the incidence has not declined, which means that we are not, probably the failure is either in the therapy or the escalation of therapy or the detection due to limited access to healthcare in screening, in identifying these people, right? And as such, when you look at it, you see that the most people who are on hypertensive emergencies are not on any medications. Now the next question, how is it identified? Of course, this needs to be a rapid identification based on history examination. Of course, given the emergency nature, it has to be a focused assessment in the emergency department. This is acute management, right? You look for cardinal symptoms, and then you do a focused examination. Again, nowadays it is important to understand, I suppose maybe even in our country, that drugs of abuse is a cause for a very high blood pressure. So you have to keep that also in mind, especially if a young person is presenting. And then depending on your now you will understand, in order for us to get to a target organ based on investigation, you need to have some rational idea, right? Whether it's an echocardiogram, whether it's a chest X-ray, whether it's a CT, etc., will depend upon your appropriate characterization of the presentation. Because you can't do anything in this patient, because you need to intervene, right? So then focused investigations, depending on, you will not be doing all of these in all the patients, but these are some of the things which needs to be prioritized based on what you identify, right? Since the students are here, I thought I will put some pictures also. This is an example of a fundus, where you see the papilledema and the flame-shaped hemorrhages. And then the other diagram is a patient with encephalopathy, where it's MRI. And the reason why you get predominantly in the posterior side of the brain is because that is where, when the pressure rises, the posterior part of the brain is where the sympathetic innervation is the lowest. So the autoregulation starts failing in the posterior part of the brain, where the edema starts to build up. So then that is why you get symptoms like cortical blindness in these patients because of that. That is the mechanism behind that. So this is probably a schema of how you can go about it. You don't need to this highlights the concepts of prioritization. Depending on the presentation, you sort of prioritize the investigations. This is actually from the European guidelines. There is a summary document on management of hypertensive emergencies. And this nicely summarizes how the things should go. I don't plan to take you in details through these diagrams. But what I'm highlighting to you is, given the emergency nature, it needs to be a focused plan for evaluation. Again, the same thing, probably in a much nicer, I suppose, student-friendly diagram. Basically the same thing, again, about recognizing symptoms and then prioritizing investigations as appropriate, right? Right, so now we get to treatment. Now the idea is to make sure that you get the blood pressure under control in a controlled fashion. You get the blood pressure down, but you cannot go all out and rapidly reduce blood pressure, because at the end of the day, now the key organs are also have adjusted physiologically, that their perfusion is now dependent on having a blood pressure at a certain level. So if you drop it very fast, what will happen is there will be worse damage, further ischemia. So then it has to be in a controlled manner. So obviously this has to be in an area, depending on the patient's presentation, has to be in an area where this could be done, maybe in HDU, maybe in the ICU. And the presence of organ dysfunction may necessitate other organ support. but it has to be in an area where this is carefully and controlled, can be done in a controlled manner. And as I highlighted to you, and I will show you subsequently, treatment is dependent on the clinical presentation. What is the target organ affected will determine how fast you reduce it, what the first choice of treatment. Of course, it's a common pool of drug, but the choice will vary with what is identified in the individual patient. So these are the recommendations for the different categories. So again, you must recognize what it is. For certain ones, you reduce the mean arterial pressure by a certain percentage, and the recommended first line is a drug like labetalol. And then for other indications, you aim for reducing the systolic blood pressure less than 140. So likewise, it is closely tied to the clinical presentation. So these are just examples. Of course, in pulmonary edema, you will couple with a diuretic and get the blood pressure under control. So what I am trying to emphasize is, I mean, these numbers as guidelines, probably in a setting where patients are acutely managed, needs to be displayed to the management team. But what I am highlighting to you is the importance of recognition of the clinical scenario and putting the patient on appropriate therapy. Now, since this, being a pharmacologist, of course, I will very briefly talk about some of these medicines, the important properties. Now, given this is an emergency, obviously you need medicines that act fast. There's no point in giving a medicine if it is going to take hours and hours to work. And the choice of administration will be intravenous, given it is an emergency. Titration of a medicine, you will adjust the dose when the blood pressure is going down fast. You may reduce the dose, but you will take time to see a response. So there are two key properties of a medicine used in this emergency. That is the fast onset of action, and the other one is a relatively short duration of action, allowing you to titrate the infusion rates to get the blood pressure under control in a controlled fashion rather than a sudden drop, right? This is just for the interest of the students. I will not go into detail, but labetalol is the first choice for most indications because it has both alpha and beta blocking activity. So the alpha reduces the causes of the vasodilatation, and then you don't get the reflex tachycardia because of the beta blocking activity as well. And the other thing is, generally, it is a medicine that is relatively well tolerated, right? Esmolol is used in certain indications, with especially the cardiac ones. I will not go into detail. Again, something that is rapidly metabolized, so that dose can be the effect can be adjusted. Nitroprusside and nitroglycerin both depend on mediated by nitric oxide, and that causes relaxation in vascular smooth muscle, both in the arterial and the venous side, thereby reducing the systemic vascular resistance and also reducing subsequent and the ventricular filling pressure and also the systemic blood pressure. Now, there are certain problems with nitroprusside, especially if you give long term, it can lead to consequences. It is metabolized to thiocyanate and excreted, and this is a medicine probably less safer than something like labetalol, especially if you have to give it for a long duration of time, because this molecule also contains, it is something that is coupled with ferrous and cyanide. So when you give it long term, there can be consequences due to that. So if you consider medicines, you will recognize that labetalol, for that safety reason also, is something that is preferred. Nitroglycerin acts in the same manner. I will not go into details, used in certain indications. So what we have discussed so far is the importance of recognition, putting the patient into an appropriate care setting, and then controlling or reducing the blood pressure in a monitored and controlled fashion using medicines that have a rapid onset of action and a short half-life, allowing us to give them as infusions and titrate, right? But once that is done, the management does not end there. That is important to recognize, right? Survival certainly has improved, as I said, but unfortunately the incidence has not gone down, right? And the patients who specially present with this remains at increased, more than other patients, remains at increased risk of cardiovascular death. And it is important to ensure that they are regularly followed up. If there are already patients who were on medicines, find out why they were not taking them, simplify, escalate the dose, add on therapy as necessary, maybe more frequent follow-ups until you get blood pressure under control. But don't forget, especially in a young patient, as my colleague Chandrika will subsequently speak about other causes for hypertension, which is also something that needs to be kept in mind. Lifestyle, I will not go into detail, but just one sentence. Irrespective of a patient's stage of hypertension, lifestyle is part of the management. Whether they are stage 1, stage 2, stage 3, whatever, all patients need lifestyle modification. That needs to be kept in mind. Right, so final few slides. What is the future? The future is, unfortunately, there is gaps in knowledge. Now, hypertensive emergencies. Now, we all talk about evidence-based medicines, but and most of our evidence come from the top of the pyramid that I have shown here. All of you all are familiar with this, where there are randomized trials, meta-analysis, and so on. But unfortunately, for things like hypertensive emergency, except in stroke, there is absence of randomized controlled trials. So the evidence is dependent on expert opinion, consensus, and things like in guidelines, right, to a certain extent. And the understanding of the pathophysiology is poor. And the other thing that this is not for only emergencies, the other thing that we are increasingly recognize is that there is a greater impact on ethnicity on all these medicines, right? And we straight away adopt guidelines that are coming from European countries, which are predominantly in Western European populations. And even for hypertension, the recommendation varies whether you are African or whether you are of European or white origin. But do South Asians respond same to the set of medicines? We do not know. We have evidence to show that for medicines like statins, we don't require the same high dose, right, from data from Sri Lanka, because genetic variations. So the impact of genetic variations on the hypertensive medicines is something that we don't know about, right? So that is a gap. And this I have told, and other speakers have also spoken. There is certainly a gap in identification and appropriate therapy, which I will not go into detail. So the two key messages from the talk is patients with hypertensive emergency is life-threatening condition, needs to be admitted for close monitoring with appropriate reduction of blood pressure depending on the organ affected. But there will be another large portion of patients who present with elevated blood pressure who, after careful evaluation, you find that they don't have target organ damage. So those patients can be safely discharged home after careful observation and starting appropriate therapy. But you need to make sure that they are appropriately followed up. They are given appropriate education about the seriousness of their condition so that they go on medication therapy appropriately and don't end up getting hypertensive emergencies. These are the two documents for which the details that I present were derived from. There is a recent guideline from the European Society of Hypertension, which has a short summary on hypertensive emergencies. Then there's a paper in 2019 which gives a detailed management about hypertensive emergencies for anyone interested. And these are all open access papers you can get. Right, so what we discussed during this session is basically answer to these questions, the definition, the pathophysiology, the epidemiology, and once how to identify it, after identification, how to start treatment, and then subsequent management. And I will end with this, and as we know that we have this hypertension day today, it's basically to raise awareness. And one of the campaigns that is happening in Sri Lanka concurrently to raise awareness is this May Measurement Month, which just started today. It's an island-wide screening program, including being conducted in Colombo. So if anybody is interested to join the program, they are welcome. So with that, I end the talk. Thank you very much.
Thank you, Professor Priyanka. And before moving on for the next lecture, we are open for any questions from the audience. So the audience is if you got any questions, please raise your hands. We are more than willing to respond to your questions. Yes, so it seems there are no questions. We are moving on with our schedule, and our next lecture will be on management of hypertension in kidney disease, which will be delivered by Dr. Dilushi Vijayaratna, consultant nephrologist, lecturer, Department of Clinical Medicine, Faculty of Medicine.
Thank you. So first of all, I'd like to thank the organizers of this event and Professor Katulanda for inviting me to deliver this talk. My topic is a little bit more specialized, but CKD is very common, and hypertension in CKD is also very common, so it's a good idea for everybody to have some awareness about this topic. So as I said, hypertension is a common comorbidity in chronic kidney disease, and it is both an effect of and a contributor to CKD and its progression. It is a risk factor for cardiovascular disease. We saw that it is the leading risk factor, if at all. And cardiovascular disease is the commonest cause of death in chronic kidney disease. Blood pressure can be more difficult to control in patients with chronic kidney disease, and we often come across particular challenges when we are managing hypertension in these patients, such as hyperkalemia, and also changes in serum creatinine with fluid shifts. So if we pause to think about what we are trying to achieve by treating hypertension in these patients, of course we are trying to improve survival, which is mainly by reducing cardiovascular death, and we are trying to improve morbidity, again mainly by reducing cardiovascular disease and reducing CKD progression. And we also want to make sure our patients have a good quality of life. And quality of life can be quite a subjective concept and may depend on the patient values. So some people may not want to have a lot of blood tests and may not feel comfortable with a lot of anxiety about the blood tests also. So my talk is focused mainly on this guideline. This is the KDIGO guideline. KDIGO is the Kidney Disease Improving Global Outcomes Group, and it is endorsed by the International Society of Nephrology. So the nephrologists have also got together and discussed the evidence and developed their guideline. And this is heavily influenced by a trial called the SPRINT trial. So you may find that some of the conclusions that the nephrologist community has come to are a little different from the conclusions of the cardiology and endocrine communities. And I think that is a common problem you see. There are multiple targets for managing blood pressure because there are still some controversies which we're not sure about. But this guideline is very heavily influenced by this particular trial that I'm going to describe. So the SPRINT trial was published in 2015, so it's been almost 10 years now, in the New England Journal of Medicine, and it was a randomized, controlled, open-label, multi-center trial. It recruited patients with high cardiovascular risk. So how did they do that? By choosing patients who were over the age of 50, who had a blood pressure of, a systolic blood pressure of 130 to 180, a high cardiovascular risk score, but they excluded patients with diabetes and with stroke. And these patients were randomized to receive either intensive blood pressure control or standard treatment. Intensive blood pressure control was a systolic blood pressure of less than 120, and standard treatment was our usual target of less than 140. There were over 9,000 patients recruited to this trial. The primary outcome was a cardiovascular outcome, which is understandable because cardiovascular disease is the main problem in hypertension. This was a composite outcome for the first occurrence of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death from a cardiovascular cause. And then they had another outcome, death from any cause, right? And there were many other secondary outcomes. So the trial was stopped early at a median of 3.3 years because there was overwhelming evidence of effect for this primary outcome in the intensive treatment arm. Now, why am I talking about SPRINT, particularly in the context of CKD? It had certain kidney-specific elements. It included patients with an eGFR of 20 to 60 as one of those cardiovascular risk factors. It excluded certain patients, those with an eGFR of less than 20, so that is around CKD 4 and 5, and patients on dialysis. It excluded patients with proteinuria of 1 gram per day, because there's already some evidence from other trials that this particular category of patients benefits from more intensive blood pressure control. It excluded patients with glomerulonephritis on immunosuppression, because we know immunosuppressive treatment can confound the interpretation of the results, and also excluded patients with polycystic kidney disease, a category in whom, again, intensive blood pressure control had already been shown to reduce CKD progression. And they were kind enough to have a CKD subgroup, which was pre-specified. More than 2,600 patients were recruited specifically because they had CKD, so that the SPRINT trial cohort would include this CKD subgroup. Overall, looking at the CKD patients and comparing them with the non-CKD patients in SPRINT, they were older, as you might expect, more women, and more of them had prior cardiovascular disease. The mean eGFR was around 47, and the mean urine ACR was 80.6. So not a lot of proteinuria, right? And also not very low GFRs. But we see a lot of patients like this in our clinics. As expected, the patients with CKD needed a slightly more blood pressure tablets to control the blood pressure. Now, as I mentioned at the beginning, the primary outcome of cardiovascular disease and death was lower in the intensive treatment arm compared to the standard arm for the whole SPRINT cohort. And when you compare that outcome between the CKD and non-CKD groups, there was no difference. So it doesn't appear that patients with CKD are responding differently to this treatment compared to those without CKD. The same applied to death, and the same applied to the combination of this primary cardiovascular endpoint and death. There was one concern about whether lowering blood pressure could affect cognitive outcomes. And if at all, it seemed to be that there was less cognitive impairment with better blood pressure control compared to standard treatment, but definitely no signal to say that there were worse cognitive impairment outcomes with intensive blood pressure control. Now, this was when they categorized chronic kidney disease based on a cutoff of eGFR of less than 60. So those with a GFR of more than 60. So those with a GFR of more than 60 were non-CKD. Those with a GFR of less than 60 were considered to be CKD. When modeled as a continuous variable, so when they took eGFR as a continuous variable, as a post-hoc analysis, they did notice that the cardiovascular benefits might have been progressively falling as the eGFR fell. So that suggests that as the eGFR becomes lower and lower, you are less likely to benefit from this intensive treatment. That doesn't mean to say that they were having more adverse events. But this was a post-hoc analysis. There were only a few events in these subgroups, and therefore, though it's food for thought, we can't really come to any conclusive evidence. And I think overall, the take-home message is that CKD doesn't really behave differently from non-CKD patients. Now, as when we're talking about chronic kidney disease patients, we're particularly interested in the renal outcomes. And the SPRINT trial looked at kidney outcomes in the intensive and standard blood pressure control arms as another secondary outcome. So the kidney outcome that they were looking at was 50% reduction in GFR or progression to end-stage kidney disease, which is going on dialysis or having a transplant. So the overall kidney outcome was no different between the two groups. So it didn't seem as if intensive blood pressure control was actually going to improve the renal outcomes in this group of patients. But mind you, these patients were at low risk of progression to CKD anyway because they had very minimal albuminuria. There were no diabetics in this group, for example. What was of concern was that there was a higher proportion of patients having incident CKD in the non-CKD group. So that is, the patients who didn't have CKD were more likely to develop CKD if they were given intensive treatment. But this diagnosis of CKD is simply based on a GFR measurement. And incidental CKD was defined as a 30% decrease in GFR to less than 60. So while some people might be concerned about this, we should realize that serum creatinine is just one measurement, and it is not actually a way of measuring GFR, but only estimating GFR. And there are many, many limitations in its use. We already have experience with drugs like ACE inhibitors, ARBs, and SGLT2 inhibitors, where we know that after initiating the drugs, due to hemodynamic effects, the serum creatinine can rise. But in the long run, they are beneficial in terms of preventing CKD progression. Now, in keeping with that hypothesis, there was less albuminuria in the intensively treated arm, suggesting that this rising creatinine was more due to a hemodynamic effect than due to actual kidney injury. And similarly, there was no increase in urine biomarkers of tubular injury in the intensively treated group. So, as a whole, this doesn't really seem to be a cause for concern. And it may be that they may actually benefit from this treatment in the long run, particularly if used in a high-risk treatment. And hypo and hyperkalemia were also more common in the intensive arm, as you would expect, because they would have been treated with more agents like ACE inhibitors, ARBs, and diuretics. So the key messages for SPRINT were that aiming for a systolic blood pressure of less than 120 versus 140 improves cardiovascular outcomes and reduces deaths, and the effects are not modified by the baseline CKD state. There's no clear evidence of improvement in kidney outcomes. Concerns of adverse kidney outcomes are likely unfounded as urine biomarker profile and albuminuria improve with intensive treatment. Other trials, like the MDRD and ASK, do support more intensive blood pressure control in proteinuric CKD patients for improving kidney outcomes. Adverse events, which is what we're very worried about with intensive blood pressure control, and which is why there's so much resistance in adopting a lower threshold in many other guidelines, were not particularly high in this SPRINT cohort. Albeit, of course, we had to understand that this was a trial setting where patients get more care. But there was no increase in cognitive decline, there was no increase in orthostatic hypertension, but there was, as expected, more hyperkalemia and AKI, but didn't really lead to any clinical problems. So SPRINT, like I said, heavily influenced the KDIGO guidelines, and I'm going to talk about 5 aspects that are emphasized in the guideline, that is measuring blood pressure, the target, the agent, special group, that is kidney transplant recipients, and general advice. So how did they measure blood pressure in SPRINT? They used what is called standardized office blood pressure measurement. And you have heard this repeatedly over the last few talks. So it's not an easy process, it's quite laborious. Patients have to have avoided coffee, exercise, smoking for 30 minutes, have to have an empty bladder, have to be in a quiet space where they're undisturbed for about 5 minutes, and then have to have their blood pressure measured using a validated, calibrated blood pressure apparatus. Specific posturing for the measurement with the arms supported, the cuff at the level of the right atrium of an appropriate size and with no clothing under the cuff. And then a particular technique for measuring the blood pressure if it's auscultatory method guided by the Korotkov signs. So each measurement has to be done twice in both arms. The higher arm selected for blood pressure measurement at future use, and then the second measurement is taken at 1 to 2 minutes later. And then the average of 2 or more readings is taken on 2 or more occasions. And so you'll understand that this is practically very, very difficult to do. But having said that, blood pressure is a very variable thing. So unless you measure it in a standardized way, you don't really know what you're treating. You don't really know whether the patient has high blood pressure or not. So in the guideline, they do really emphasize trying to develop a system where you can measure blood pressure in a standardized way, and that should not be an obstacle to implementing the targets that are recommended in the guideline because of the overwhelming cardiovascular benefits that you get by treating to target. Some things that we can do while we're trying to set up standardized office blood pressure measurement is using out-of-office blood pressure measurements to complement the office blood pressure measurement. And that is what we've been talking about, like home measured blood pressure and ambulatory blood pressure monitoring. And apart from helping us understand our office-based blood pressure a little bit better, they can also be used to detect white coat hypertension and masked hypertension. So, standardized blood pressure is really emphasized in the guideline, and that is probably the main thing because nothing else in the guideline can really be implemented unless you use standardized blood pressure. It allows the extrapolation of targets from large RCTs to the clinical setting. So every trial that we try to follow in a guideline has measured blood pressure according to a particular technique. So unless we follow that particular technique, we're not really implementing what that guideline, what that trial has found to be effective. So having this standardized blood pressure measurement is what allows us to apply that evidence into day-to-day practice. There is a risk of overtreatment in general if we apply these blood pressure targets to office blood pressure, because usually office blood pressure is higher, routine office blood pressure. But we understand it requires time, staff, space. The device is not critical, so it doesn't really matter if you're using your mercury sphygmomanometers or whether you're using automated devices. Like I said, home monitoring and ambulatory monitoring can help, but there are no evidence-based targets yet for these out-of-office devices and measurements. So the guideline sticks by SPRINT and suggests aiming for a systolic blood pressure of less than 120 millimeters of mercury, and this is as a standardized blood pressure measurement. Why? Because it reduces cardiovascular events and all-cause mortality in CKD, and they feel that patients would value this. Patients and healthcare systems would value this outcome over the inconvenience of standardized blood pressure measurement. In most patients with high blood pressure, including the frail and the elderly, these benefits appear to outweigh the risk of harm. There are subgroups of concern, right? So this was a trial, and the results are an average. They're a population level. So at individual level, you would have to individualize your management. There are subgroups of concern, particularly those who are not included in the trial. So those with CKD 4 and 5, diabetic patients, individuals with a systolic blood pressure of 120 to 129, those who have very low baseline diastolic blood pressure to start off with, patients with polycystic kidney disease who may actually benefit from an even lower blood pressure target, and the very young and perhaps the very old and the very frail, right? So even among diabetics, so even though they were not included in the SPRINT trial, they were included in the ACCORD trial. And in the ACCORD trial, as was discussed earlier, intensive blood pressure control did improve the rates of stroke. So even in diabetic patients with kidney disease, it would still be reasonable to aim for a systolic blood pressure of less than 120. So which antihypertensives should be using? As we have been saying, reaching the target is more important than the agent, but if you have a choice, the best antihypertensive drug for a patient with chronic kidney disease is either an ACE inhibitor or an ARB. And you can see that in these forest plots here, which demonstrate the results of a network meta-analysis of 119 randomized control trials with over 60,000 patients. ACE inhibitors and ARBs were better at preventing kidney failure as well as cardiovascular events in patients with chronic kidney disease. That is compared to placebo as well as compared to active control. And this is highlighted in this visual abstract, which demonstrates the choice of antihypertensive in patients with CKD, stage 1 to stage 4. If you look at the top line here in green, whether you are diabetic or non-diabetic, whether you have albuminuria or you don't have albuminuria, if you're in CKD 1 to 4, basically you should be on an ACE inhibitor or an ARB. The evidence for that is stronger if you have more albuminuria, right? But that is because there have been more trials in these patients and they're at higher risk, so it's easier to demonstrate a benefit. So we need to use these drugs, and here are some tips for using them. Aim to use the highest approved dose that is tolerated. So we have a bit of lethargy when it comes to achieving the highest approved dose. We should try to achieve that because it's that dose that has been proven in trials to improve outcomes. We should check the serum creatinine and potassium in 2 to 4 weeks after initiation or after dose change, depending on the GFR and potassium. Up to a 30% rise in serum creatinine within 4 weeks is acceptable because we know it can be due to hemodynamic effects, and these patients stand to have long-term benefit from these drugs. If there is hyperkalemia, try to use other measures to address the hyperpotassium rather than stopping the drug. The dose can be lowered in symptomatic hypotension, uncontrolled hyperkalemia, or to reduce uremic symptoms in advanced CKD. So patients at the later stage of CKD are always a difficult group to handle because the drop in GFR in a patient who's in CKD 5 can actually precipitate symptoms of uremia and fluid retention. So you'd have to really have a patient-by-patient decision about whether to start an ACE inhibitor or an ARB in that category. So this is an algorithm which demonstrates what I've been saying. Once you start a patient on an ACE inhibitor or an ARB, you check the serum creatinine and potassium in about 2 to 4 weeks. If the potassium is normal, you're happy. If the eGFR has not increased by more than 30%, you're even happier. And you can increase the dose to the maximally tolerated dose. If, however, there is hyperkalemia, then you review the concurrent drugs. Is there anything else that can be causing hyperkalemia here, like NSAIDs, certain antibiotics like cotrimoxazole? You try to moderate the dietary potassium intake by advising the patient on diet and consider adding something else to help with this potassium, such as diuretics, sodium bicarbonate if there's metabolic acidosis, and potassium binders. If the GFR increases by 30% or more, look for any other causes of AKI. We know that volume depletion is going to aggravate this drop in GFR, which occurs after starting ACE inhibitors or ARBs, so that needs to be corrected. Reassess whether certain concomitant medications like diuretics and NSAIDs need to be given, and think about whether the patient might be having renal artery stenosis. If you can't manage the hyperkalemia and the rise in GFR with these measures, then you would have to reduce the dose or stop. And once this has resolved, it's always worth coming back and rethinking at a later stage whether you can restart these drugs. So we've talked a lot about diet in hypertension, and potassium in the diet is something that patients are very worried about. So this is some interesting evidence from the latest KDIGO guideline for the management of chronic kidney disease, where they recommend a plant-based diet, which is what we have been telling our patients to kind of avoid in CKD, because the high amount of alkali in the plant-based foods, as well as the high amount of soluble fiber, actually reduces the amount of potassium that is absorbed and that eventually influence the serum potassium. So this shift from animal-based foods to plant-based foods, which we have been reinforcing as part of hypertension management, applies to potassium management as well. And avoiding processed foods is very important, and it's something that's very easy to do because the absorption of potassium is very high when it's from processed foods. So RAS inhibitors are clearly the first-line drugs, but what about beyond the first drug? There's no real evidence base for this. Reaching the target is probably more important than the agent that you use. Often we will use a thiazide or a CCB in combination. We don't use the combination of ACE inhibitors and ARBs. It's always one or the other. Second line, once you've tried these drugs, you can try for beta blockers and alpha agonists. And I should emphasize that, as Dr. Anidhu mentioned, a diuretic is very important in the management of hypertension, particularly in patients with CKD, where salt and water retention contributes to hypertension. Third line are these less favorable drugs. And perhaps if you're reaching for third line agents, you should be wondering if you really need to go so low. So you need to reassess your targets if you're reaching for the third line drugs. Just a few words about kidney transplant recipients. So the targets for kidney transplant recipients are slightly different, and that's not based on any particular evidence. Systolic blood pressure of less than 130 and a diastolic of less than 80. And this again reflects that fear that we have about lowering blood pressure too much. We understand that these patients are very worried about their serum creatinine levels, and so are nephrologists looking after these patients. So small fluctuations in the creatinine because the blood pressure goes down a little bit might cause unnecessary anxiety, unnecessary investigations, and so on. So it was the recommendation of the group that based on this, it may be wiser to have a more relaxed blood pressure target in this particular category. But some patients might actually prefer the cardiovascular benefit of having a lower blood pressure, and that is probably something that can be discussed with the patient. The agent to use preferably is a calcium channel blocker or an ARB. If the patient is overloaded, of course, you would try a diuretic. If planning pregnancy, as was mentioned earlier, we would try to avoid ARBs, or we would avoid ARBs, and a CCB would be preferred. And early post-transplant, again, we avoid ARBs because they can cause fluctuations in the creatinine, and then we wouldn't know for sure whether this is hemodynamic effect or whether it's actually due to some kind of intrinsic renal problem like rejection. So you can use other agents like ACE inhibitors, alpha blockers, beta blockers, and so on, but there's no evidence that they have any particular mortality or renal benefit apart from that of lowering blood pressure. So lastly, there's general advice again in our guideline, common to what was mentioned in all the other talks today: lowering salt intake, improving physical activity, reducing weight, reducing alcohol, and a healthy diet. With regard to reducing sodium intake, it's just important to note that there are salt substitutes which contain potassium, which should be avoided in these patients. And also salt reduction is not advisable for patients who have salt wasting nephropathy. So this evidence again does not come from the CKD group, this comes from the general population, but we think that there's no reason that these lifestyle interventions would not be advisable in CKD patients as well. So in conclusion, this is just a guideline, and guidelines are not rules or law. The results of the trial and the ideas, concepts of the guideline are applicable at population level and not necessarily at individual level, and therefore we need to individualize our treatment to the particular patient. So we need to weigh risk and benefit and also the patient's preference and values. We should be aiming for standardized blood pressure measurements because that's the only way we really know what we're doing. And I appreciate that that's difficult to do. And there are still many gaps in this CKD population, such as the blood pressure targets in dialysis patients, and also what to do in patients with more advanced CKD, like CKD stage 5. So thank you very much.
Thank you, madam. If the audience is having any questions, you can raise them now. Okay, in the absence of any questions, let's move on to our next lecture. Our final lecture for today will be on endocrine hypertension. Please welcome Dr. Chandrika Subasinghe, consultant endocrinologist from Colombo North Teaching Hospital, to deliver the lecture.
Okay, good afternoon to you all. So it is the last talk of the day. Probably everyone is hungry. So first of all, I would like to thank Professor Katulanda for inviting me to be a part of this. So the last topic is kind of like the icing of the top of the cake, I would say. It's the endocrine related hypertension. So we were talking about a very common disease all this time, hypertension. We said everyone is having hypertension, but I'm going to talk to you about a very kind of uncommon condition, the endocrine hypertension. You may have seen patients with endocrine hypertension, or you may not have seen. So so I can't talk about population-based management of endocrine hypertension. So I'm going to discuss very few case stories with you and tell you how they present and how do we evaluate them and how do we manage. So my objectives you can't see. So I'm going to tell you whom we need to evaluate for secondary hypertension, including endocrine hypertension. Then let's discuss few interesting cases. So hypertension is a global epidemic, and most of these patients are having essential hypertension, and there is there's a small group of patients who are having secondary hypertension. What is secondary hypertension? That means the hypertension or high blood pressure is due to an underlying secondary cause, and it is very important for us to find out this, pick up this group. Why? Because most of their blood pressure is difficult to control. They are having severe resistant hypertension. But if we find the underlying cause, even we can cure their blood pressure. So that is very important to pick up these patients, evaluate them, find the cause and treat. So as I said, this is not very common. So when we diagnose patient with high blood pressure or when we follow them up, we can't be investigating all the patients for a secondary cause, because most of them are having essential hypertension. So we need to know whom we are going to evaluate for a secondary cause. So for that we need to look for clues, right? Sorry. So the general clues, sorry about this, something wrong with the font. So there are general clues. What are the general clues? If our patient is having the severe or resistant hypertension, then that means we need to be alarmed, and this patient may be having an underlying cause and having secondary hypertension. And if our patient is having the onset of hypertension, when we diagnose the hypertension, if the patient was young onset hypertension without significant family history or the metabolic syndrome, then that also a general clue that the patient may be having underlying cause. So this throughout the lectures, this was discussed about the resistant hypertension. What is resistant hypertension? If we can't control their blood pressure with the maximum tolerable doses of 3 antihypertensives, including diuretic, then we call it resistant hypertension. So we come across a lot of patients who have apparent treatment-resistant hypertension, but not all of them are having true resistant hypertension. Professor Priyanka was talking, lot of patients are not compliant with the therapy. We know our patient take the medications and make a drugstore at home. They never take it. So that may be the reason why they are having apparent treatment-resistant hypertension. So we have to find that out. Then there are patients with pseudo-resistant hypertension. That means, like this was also discussed, when the patient comes to us, they become very anxious and their blood pressure go up. We sometimes call it white coat hypertension. So for that, we can measure their blood pressure at home blood pressure monitoring or ambulatory blood pressure monitoring. We can use that to take this part also out and find out who are the patients who are having true resistant hypertension. Then we have a general clue. We think this patient may be having secondary hypertension. Then we need to look for specific clues. That means any clues to suggest that patient may be having some disease which can cause hypertension. For that, we need to know what are the possible underlying causes and look for the signs and symptoms of those causes. So what are the common causes? Dr. Dilushi was talking about the kidney disease. It is one of the causes for secondary hypertension and the renovascular hypertension. And there are young females coming with connective tissue disorders, vasculitis with hypertension, and there may be drugs which cause hypertension, and sometimes the drug abuse also cause for hypertension, and the coarctation of aorta and obstructive sleep apnea is increasingly recognized as a cause for hypertension. And then comes the endocrine hypertension. So there are a lot of causes. Mostly the diseases of adrenal causes secondary hypertension. In addition, acromegaly, thyroid disease, hyperparathyroidism also can elevate the blood pressure, not very significant. Okay, so since it is mainly the adrenal diseases which cause endocrine hypertension, I will be discussing few of adrenal hypertension cases. So we have to clinically then evaluate the patient to see whether we have any clue for that. So sometimes some of the patients with endocrine hypertension, when they walk into the clinic, you can recognize. Even an acromegaly patient, if you have come across at least once, maybe you can, when the patient walks on the road also, you can recognize. Have you anyone who have seen an acromegaly patient? Okay, so acromegaly patients are like giants. They have acral enlargement, they have big hands, big feet, and they have frontal basin prognathism. They are like very kind of giants. So even like I have seen a lot of acromegaly patients, so even in the supermarket, if I see one, I can recognize, right? So that's very clinically obvious. And then Cushing syndrome, that is also a cause for hypertension. Anyone who has seen Cushing syndrome patient? Okay, so there are some. So they have the typical clinical picture, the round face, post-cervical fat pad, and thin skin, central obesity with thin limbs, white purple striae. Okay, so they are also kind of clinically obvious sometimes, and if you have seen, few, then you can recognize. And the thyroid disease, all those things also may be clinically obvious. And then when we, if we suspect a patient with secondary hypertension, then we need to do a basic workup. What are these? We need to definitely do serum creatinine to find out whether it is CKD and look at the UFR to exclude proteinuria, nephrotic syndrome. Those can cause secondary hypertension. Then look at the full blood count, check electrolytes. Have you noted all these patients with secondary hypertension? We do electrolytes to look at the, what is the electrolyte we are looking at? It's potassium mainly, right? I'll tell you why. And then you look at calcium and do a metabolic screening. And everybody should get an ultrasound scan of the kidneys done with the renal artery Doppler to see whether there are changes of chronic kidney disease and renal artery stenosis. And 2D echo, the patient will have to see whether there is coarctation of aorta, right? After excluding the other causes, and if all these investigations, maybe except the electrolytes, all are normal, then we think of endocrine hypertension, and you refer the patient probably to the endocrine clinic. Right, so we'll discuss few cases of endocrine hypertension briefly, and I'll be very simple as much as possible. So as I said, most of the time it is diseases of adrenal. We know, can you remember anatomy? So the adrenal gland has two parts, adrenal cortex and the medulla. Adrenal cortex secrete two hormones, there are three hormones, but we are interested in cortisol and aldosterone here. And then the medulla secretes epinephrine, norepinephrine. If the secretion is, if the adrenal secretes any of these hormones in excess, that can cause high blood pressure. Okay? Okay, case 1. So this is a 25-year-old male presented with severe hypertension with blood pressure of 210 by 110. History and examination was otherwise unremarkable. The patient required 3 antihypertensives, including a diuretic, to control the blood pressure, and there was no significant family history. But patient was noted to have repeatedly hypokalemia. Potassium was low, 2, 1.8, 3, like that. And then other basic investigations, including renal functions, were normal. And when the ABG was done, that showed metabolic alkalosis. And ultrasound scan KUB 2D echo was normal. The basic workup was normal other than low potassium. In summary, the patient was a young hypertensive with severe hypertension, hypokalemia, metabolic alkalosis with otherwise unremarkable history and examination. Looks normal. So what could be the cause? Anyone who have seen a patient like this? Maybe PG trainees, if they are there, doctors. What do you think? What it could be? Okay, so this is unremarkable history and examination with high blood pressure, with low potassium, maybe high aldosterone secretion, hyperaldosteronism we call it, right? And so in the morning also in the lectures, they were talking about this RAS system, renin-angiotensin system, renin-angiotensin-aldosterone system. Here I am interested in the last hormone, the aldosterone. So if the aldosterone secretion is high due to some reason, it can act on the kidney and cause hypertension, hypokalemia, and metabolic alkalosis. So you may have seen, especially we do this in the clinics, but even in inward patients, we measure some hormones when they come with this secondary hypertension. Those are aldosterone, renin, and we do the ratio of that, aldosterone-renin ratio, right? So we usually order aldosterone-renin ratio. Our nurses also must have seen, they take blood for aldosterone-renin ratio. We prepare the patient for that and take blood, right? So there we measure aldosterone, renin, and the ratio. So what happened here? If the aldosterone, there is excess secretion of aldosterone directly from the gland, maybe from a tumor or something like that, then patient's aldosterone will be high, but this high aldosterone will have a negative feedback on the renin production, so the renin secretion will be suppressed and you will have high aldosterone renin ratio. Okay, so this is called hyperaldosteronism with suppressed renin activity. So it is primarily a problem with the adrenal gland. There may be a tumor or there may be a genetic problem and the gland is secreting too much aldosterone. And then sometimes the problem may start at the level of renin. There may be high renin secretion, and because of that will stimulate the system and there will be increased aldosterone secretion. So you will have the similar picture, but when you measure the aldosterone, renin and ARR ratio, aldosterone will be high, renin will also be high, and the ratio will be low. So it may be due to bilateral renovascular disease, or in malignant severe hypertension also this can happen, secondary hyperaldosteronism. Okay. And then there may be some patients when we measure the aldosterone and renin, both are low, but the patient has the picture similar to high aldosterone level. So that is due to something which mimics the action of aldosterone but not aldosterone. So these are very rare diseases. Even Cushing syndrome gives rise to similar picture. So anyone who is doing PG exam, so this is a kind of a MCQ or a data question, right? Okay, so let's talk about the primary hyperaldosteronism, where the patient, the similar case I discussed was having primary hyperaldosteronism. In the past it was thought it is a rare disease, but now it has been recognized. When we screen more and more patients, the prevalence has gone up. So I was talking about hypokalemia all the time, but it is a positive clue to say that the patient may be having the primary hyperaldosteronism, but all patients with hyperaldosteronism do not have to have hypokalemia. They can have normal potassium levels also. So having normal potassium does not exclude primary hyperaldosteronism. So if the patient's potassium is normal, we have to think of primary hyperaldosteronism. It is not exclusion criteria to do aldosterone-renin ratio. That's what I want to tell you. And so there are other indications other than moderate severe hypertension, resistant hypertension. There are other indications to perform this test, screen for hyperaldosteronism. Those if the patient is having spontaneous or diuretic-induced hypokalemia, patient with adrenal incidentaloma and hypertension. There are some other indications where we need to perform this test and screen for this condition. And one important thing, when you are ordering this test, aldosterone-renin ratio, as I said, you know that most of the medications, antihypertensive medications we use are attacking the RAS system. So most of the medications we use have interference on this aldosterone-renin ratio test. So ideally, if we can stop these interfering medications and put them on alternative medications and do the test, then we will get the very kind of reliable good results. But always that is not possible because we can't stop these medications because their blood pressure is high, they are having resistant hypertension. In that case, we can proceed with the test while they are on the medications but interpret the results knowing that the patient was on these particular medications. Okay? And you may have seen when we perform ARR, sometimes we prefer to put them on drugs like Processine and Verapamil because these are the drugs with minimal interference for the test. But as I said, it's not a must to change the medications. And I'm not going to go into the details. So when you measure the test, if the ARR is high and if the patient is having very, very high aldosterone levels, then even without further testing, you can say, okay, this patient is having primary hyperaldosteronism. So then, if we, when we diagnose this, the treatment is, if we can find the tumor in one of the adrenals. You know there are two adrenals. So if we have a tumor in one of the adrenals which secrete this secrete aldosterone, and if we can find that, then we can cut it off and cure the disease or control the blood pressure very well. So the next step is to find out whether this patient is having a surgically resectable cause for this hyperaldosteronism. Okay, so for that we can do the imaging, we can do CT scans, MRI scans, and then sometimes we take blood from both adrenals and see from which side is the aldosterone excess coming. So that is called adrenal venous sampling. So with all these things we can find out whether there is a tumor in one of the adrenals which secrete high aldosterone levels. Then we can take off that adrenal. So if you are from surgical wards, you may have heard laparoscopic adrenalectomy is done for Conn syndrome or primary hyperaldosteronism. Then patient's blood pressure will be cured. Okay, so the case 2. So this is a 35-year-old male presented with episodic palpitation, sweating and hypertension, and he was on 4 antihypertensives with intermittent fluctuations in the blood pressure. And his brother underwent nephrectomy for renal cell carcinoma. The other basic investigations were normal, ultrasound KUB, 2D echo normal. And this is again a young male with episodic palpitations and sweating with fluctuating blood pressure. And there's a family history of renal cell carcinoma. Any ideas which this could be? Anyone have seen this sort of patients? Episodic palpitation, sweating, uncontrollable blood pressure, young patient. Okay? It could be pheochromocytoma. Okay? Right. So what is pheochromocytoma? It is a tumor in the adrenal gland which secrete excess amounts of epinephrine and norepinephrine. And the paragangliomas are tumors in the sympathetic chain. So it can be a sporadic tumor or it can be a part of a hereditary syndrome. You may have heard of a syndrome called von Hippel-Lindau. So there you get the pheochromocytoma and renal cell carcinoma. It may be the cause because his brother had von Hippel, the renal cell carcinoma here. And so they have typical clinical manifestations, palpitation, the triad. Can you remember the classic triad? The palpitations, perspiration and pain and many other symptoms. So you have to do a clinical, take a good clinical history to see whether the patient is having these features. And then what is the test we are doing? The screening test. Anybody who has ordered 24-hour urinary VMA, 24-hour urinary metanephrine? Okay, so those are the two tests we do in Sri Lanka. If we think the patient is having possible pheochromocytoma. So the patient has to collect urine for 24 hours and send for this. These are metabolites of those epinephrine and metanephrine. So VMA, if we are doing, there are a lot of drug and food interference, and it's not a very specific test. It was the test we were doing some time back, but now we have the facilities to do urinary metanephrine. That is a better test and it has less drug and food interference. Okay, so your patient might come, and even from our nurses they might ask how to do this test and what is this test. So it is a test we do for screening for pheochromocytoma. They have to collect urine maybe from 7 a.m. today to 7 a.m. tomorrow. Collect 24-hour urine and hand over the bottle, so they will measure it. Okay. And then if it is the test results are positive, then we have to find out whether there is a tumor somewhere. We can take off. Always in endocrine hypertension, we are looking for a tumor which secrete these hormones. Then that is the win-win situation. We can take off that tumor and cure their blood pressure. Okay, here also we are looking for a tumor, and we can do CT, MRI, and there are special other imaging studies we can do. And if you find a tumor, again we can hand over the patient to the surgeon. Surgeon can take off that tumor and cure the disease or control the blood pressure very well. And if you ever had a patient with pheochromocytoma in your ward, maybe in a surgical ward, you may remember everybody was excited in the perioperative period, and you had to prepare the patient very well. You have to give alpha blockers, processine, drugs like that, and then give replete the intravascular volume and prepare the patient very well for the surgery well ahead. Otherwise, during the surgery and post-operatively, patient can develop complications. So, very important to prepare the patient. The surgeon can't suddenly take the patient to the theatre and take the adrenal out, but patient has to be well prepared for the surgery. Okay, so the third case. So this is the last case. So it was a 65-year-old female presented with new onset hypertension and noted recent pigmentation, and also had refractory hypokalemia, and again diabetes and hypertension, refractory hypokalemia, pigmentation and body swelling. And the patient was, this is again a rare form of Cushing's syndrome, and so the patient was found to have high cortisol levels, and then we found a tumor in the thymus, which was secreting ACTH and causing Cushing's syndrome. Okay, and so Cushing's syndrome, as I said, if you have seen few Cushing's syndrome patients, you can recognize them because they have specific features, right? So they have the central obesity, thin limbs, wide purple striae on the abdomen, and like we call it moon face or round face, and the cervical fat pad, very thin, paper thin skin, and they can have fractures, they can have blood pressure, and also diabetes, all these things, right? And this is a very dangerous condition. If we do not detect these patients very quickly and treat them, they can even die. The mortality rates are very high. So the doctors, when you look at the patients, if you see an uncontrolled hypertension patient with features of Cushing's syndrome, definitely either you have to investigate or you have to refer the patient for further evaluation. Okay. And so the Cushing's syndrome, again we are looking where this cortisol coming. We are hunting for a tumor always, because then we can remove it and cure the thing, right? So it may be like ACTH, you know, the pituitary secretes ACTH, and that acts on the adrenal gland to secrete cortisol. So sometimes it may be a tumor in the pituitary, or it may be a tumor in the adrenal gland, or it may be a tumor somewhere else which leads the adrenal to secrete too much cortisol. Whatever it is, first we need to confirm the patient is having Cushing's syndrome. For that, we can we do not just measure cortisol. We give some dexamethasone. Have you heard the test called overnight dexamethasone suppression test, or low dose dexamethasone suppression test? Even in wards you might have done. We give dexamethasone at night and measure the cortisol in the morning. Over about 48 hours we give 6-hourly dexamethasone and measure cortisol. There we try to suppress the cortisol. But if the patient is having Cushing's syndrome, by even giving dexamethasone you can't suppress it, because it is the tumor is secreting cortisol excessively, right? So other than that, we can measure cortisol in urine, cortisol in saliva, etc. We are not routinely done it in the government sector. Okay, so after that, as I said, then we need to find out whether it is coming from a disease in the pituitary or disease in the adrenal glands or disease somewhere else. And if you find a tumor secreting ACTH in the pituitary, a tumor secreting cortisol in the adrenal, or an ectopic tumor secreting ACTH, then we can do the surgery and cure the disease. And if we can't find the tumor or the tumor cannot be resected, then there are medical therapies targeted at either adrenal gland or pituitary gland. So there are many ways we can manage Cushing's syndrome, but early recognition of Cushing's syndrome is important because it has a very high morbidity and mortality rate. Okay, so I think I try to be very simple as much as possible for everyone to take home something with this from this talk. So as in summary, hypertension is a very common disease, but secondary hypertension is found only in a small group of patients. So always we need to look for clues to see whether they are having secondary hypertension or endocrine hypertension. Endocrine hypertension, the commonest causes are adrenal diseases, and if they are having aldosterone excess, they can present with hypertension and hypokalemia, and normal potassium does not exclude them having hyperaldosteronism. And if you are doing the test aldosterone-renin ratio, then you need to know about the interfering medications. And pheochromocytoma, it is again can be a dangerous condition if you do not diagnose and treat. And we do a test called, we measure the metabolites of these hormones in the urine in terms of urinary metanephrine, urinary VMA, and preparation of the patient for surgery in pheochromocytoma is very important. Cushing's syndrome, you need to kind of know how to recognize the patient with Cushing's syndrome, looking at with proper clinical evaluation, and then most of these patients, these cases are very rare, so you will have to have specialist opinion, help to diagnose and manage these patients. Okay, thank you very much.
Thank you, madam. If the audience is having any questions, you can raise them now. Okay, in the absence of any questions, as we mark the conclusion of today's proceedings, let me extend our heartfelt gratitude to all our distinguished speakers for sharing their knowledge and insight with us. And also, thank you everyone for participating in today's seminar. We hope this educational seminar was informative and helpful to you all. Thank you.